All right, so today is Wednesday, the 14th of October, and we are going to talk about TBIs today. So when I say TBIs to you guys, what are some of the words that come to mind with TBIs? What kind of, let's play the association game. What comes to your mind when I say traumatic brain injury? Concussion, good. Football, brain injury. CTE, good. If that's coming to your mind because, you know, me, I'm talking pretty heavily about that. When I think of here's the interesting thing. When I think of traumatic brain injuries, I think of just about every single neurological conditions out there. And we're going to find out that really quick how much this links to everything. There's currently a research study being done at Brown that's linking TBIs to ALS, which to me is, I mean, it makes sense to me. The brain's getting basically melted with TBIs. So what does the definition of a TBI or definition of a concussion? So a concussion is a mild traumatic brain injury that is complex pathophysiological process affecting the brain induced by traumatic biomechanical forces, secondary to direct impact or indirect forces of the head. Disturbance of the brain function is related to neurometabolic function rather than to structural injury and is typically associated with normal structural imaging findings. Concussion may or may not have LOC, so loss of consciousness. It may result in a constellation of physical, cognitive, emotional, and sleep-related symptoms. So when it says constellation of symptoms, what does that mean? That's another term you may see in other diseases as well. They'll talk about having constellation of symptoms. Yeah, so it basically means they're related to each other, right? It's like you're looking up in the sky and you see that star, this star, that star. So they're not necessarily all clustered together. I mean, you don't just have all physical symptoms. You kind of pull from a little bit from everywhere. And everyone's going to have a little bit of a different result with this when they get it. One person getting a concussion may respond very differently to somebody else getting a concussion. Recovery for these may be days, maybe weeks, maybe months, or maybe never. Some people from getting a single concussion have problems that are lifelong. And that to me it's amazing. The key thing that I want you to walk away from here is there is no test right now for concussion or traumatic brain injury. The only thing we can do is screen them by their symptoms. We can put somebody in a CAT scan or an MRI of the brain, and we can take a look and maybe see some focal damage. Like if you had really, really bad direct blow, we might be able to see some focal damage. Like I said, when I fell back when I was climbing in the Valley of Fire, I fell and landed on this part of my brain here, the head right here. I had a good old noggin lump there. But when they did imaging, they could see that I've got a focal area of damage there. I had some bleeding in that area. But a lot of the other concussions I had no structural findings. They couldn't find anything in the brain. So the only thing they can do is go by the symptoms you present with. And that's kind of terrifying. Now, there is some blood work coming up that we'll talk about that's showing some promising signs about maybe we'll be able to actually do blood draw and detect concussions. The key thing that always strikes me here is just how differently everyone, oh, did my camera just tilt way up? Yeah, it did. How differently everyone responds to concussions. I've seen people that, you know, get a concussion and they're perfectly fine. I've seen some people that get concussions and they just are absolutely terrors to their family. So when we have a TBI, the first thing we have to figure out is an open or a closed brain injury. So what does that mean? Open or a closed brain injury? What do you think? Yep, there you go. That's exactly, it's all it is, Erica. Don't take any more than that. Is the skin intact or is the skin broken? Right? Is there bleeding or is there no bleeding? Now, taking it a step further, we're now starting to classify them a little bit more that open, that there's some damage to the skull as well. So that would mean that the brain cavity is now open. but it traditionally has just been, is there bleeding or is there not bleeding? Right, so did you break skin when you fell and stuff like that? That would typically be an open head injury versus a closed head injury or closed brain injury would be that you just did something, you have no appearance of that. So how do we kind of subtype these brain injuries? Concussions are kind of the most common we'll talk about. So a concussion is one where there is traumatic force movement of the brain. So with the brain sitting in your skull, the brain is mobile, right? And it should be mobile. It needs the ability that if you're walking around and you're turning your head really fast, that it can kind of float in its fluid. If you move it too fast, it can cause, you know, some shatter, some shearing of nerve endings, right? Contusion, meaning a bruise. You can get bruises on the brain. The problem with bruises on the brain is a lot of times the neuroglia will come in and scar off or glial off that area. Meaning that if you have a really, really bad contusion of the brain, they may actually just prune that whole area of the brain off that's bruised because they're like, this isn't going to heal. I'm not going to let it affect the rest of the tissue. We're just going to scar that area off. So that's why some people, when they get really, really bad impact concussions, can end up with permanent neurological symptoms, right? This is also where we get the term coup counter coup, right? So coup counter coup. Has anyone heard that term before? When a patient gets a coup counter coup injury? No, no one's awake yet. It's okay. So a coup counter injury. Yeah, there's that. That's part of it, Erica. The other part of it is, let's say that all of a sudden Eric and I are in a, we're fighting, we're sparring or whatever. And she just delivers me just the most wicked punch right to the forehead. Right? So she just, for whatever reason, lays a noggin on me right in the forehead. That is going to be my coup injury. That's the initial impact site. Because she hit me there, my brain is going to move posteriorly. Because that's what force does, right? For every action, there's an equal and opposite reaction. She hits me here, traverses force across the brain. The brain is going to go back and slosh off the backside of my skull. So then my occipital cortex is going to get the counter coup injury. So I'm going to have an injury to the front of my brain and an injury to the back of my brain. Same thing can happen from side to side, you know, at angles. The coup is where the blow kind of lands, where that initial contusion is. The counter coup is the brain moving across and hitting the other side. Exactly. It's the rattling the brain. But like, think about this for a second. Let's say that this happens. Well, that means I'm going to have a mixed bag of symptoms here because I'm going to have some frontal lobe symptoms, but I'm also going to have some occipital lobe symptoms. Right? So I'm going to have some probably impulse control. You know, I'm probably not going to be the nicest to her from punching me in the forehead. But then also I'm probably going to start developing some vision symptoms. Right? Maybe I see stars. It's a common thing you'll hear, especially in football, right? They get up and they're like, man, I saw stars. You hear somebody that says that, you know that the occipital lobe got banged really bad, right? So coup counter coup injuries. Hematomas, obviously, so a difference between a bruise and a hematoma is now that hematoma kind of starts growing in that area, right? And starts spreading. The one thing about the brain, when you get a bruise that's really bad, that, like I said, that part of the brain typically dies off. But as that area dies off, it spreads kind of almost like an infected tissue. It's not really infected, but a necrotic tissue. And it likes to eat away at the surrounding tissue. So that hematoma slowly grows unless the glial cells come in and kind of clean it up. A lot of the astroglia and neuroglia come in and kind of prune it off. And like I said, that's what they call it gleeing off or scarring off. Locked-in syndrome can occur with these people. Again, we talked about that before, where they can kind of get locked in their brain. They can get sudden impact and acquired brain injuries, meaning that just because of one impact. They may not have that coup counter coup, they just have that one impact site and they get that. And acquired brain injuries, obviously, anoxic events, everything like that, can technically be classified as traumatic brain injuries. So how do we get these injuries? Direct blows are the most common. I think I was reading when I was looking at the research last night, like 60% of the, go away, 60% of the injuries that occur are direct blow injuries. So that means they've gotten some sort of a direct blow. Can I get a traumatic brain injury from a car accident? Yeah, right. I can get a traumatic brain injury from not wearing a seatbelt, first of all, right? And my head goes banging all over the place. I can also get it from that airbag, because those airbags, I don't know if any of you have ever had one deploy on you, but when they deploy, they're not exactly the nicest thing in the world. They deploy with some force because they're trying to keep you from getting a severe spinal cord injury. In the process, they give you a traumatic brain injury, right? Concussive blasts. Who do you think suffer traumatic brain injuries here the most? What population? Yeah, the military. Absolutely. And this is way underreported. Absolutely way underreported. When we had that attack, was that a year ago, year and a half ago? This is one of the things that really bugged me. This is one of the first times that I really got kind of angry at our president, because we had that military attack on when Iran attacked our base, and he said that most of the people that were there suffered nothing more than a headache. No, 60 or 70 soldiers had to be airlifted out of that base and taken to Ramstein for traumatic brain injuries from the explosions. When those bombs go off, they create a concussive force. That's probably the worst part about a bomb, other than getting hit by it and, not living ever again, right? But when you get hit with those bombs, they send off concussive waves. So initially, when that bomb goes off, it kind of sucks in on itself and then blows out. And when that blowout comes out, it's going to send sound waves. And we know that sound waves travel through all materials. And those sound waves will go through the skull and cause the brain to basically get scrambled. Right? And, we had a long-term effect. We had short-term effect shell shock, and then we had long-term effect shell shock. Do you remember hearing about that from like World War I, World War II, and the Korean War? Right? So short-term shell shock was just getting that blast and kind of getting rattled and not knowing what's going on. Long-term shell shock, what do we call that now? We have a new term for long-term shell shock. We actually call it what it's supposed to be, right? We have PTSD, post-traumatic stress disorder. And so those concussive blasts can be really bad. And then we have the indirect brain movement, right? This is where we can get those coup counter coup injuries without even having any damage, right? If I get whiplash and my head whips forward and then all of a sudden the seatbelt whips me back, the brain's going to slosh against the front and slosh against the back, and I'm going to get some brain injury here. And that's when you call Glenn Lerner is the way to go. Call 877-1900 or 1500 or whatever it is, depending on if you're in Las Vegas or in Tucson, right? That happens. The brain is, okay, I made you laugh. I appreciate that. The brain is a very delicate device, and we don't always treat it the best. So we're going to talk about common symptoms, and we're going to talk about overall symptoms. Sad they didn't understand. It is like Eric, it's totally, yeah, she's right. So she said that, sad they didn't understand that some people are considered deserters and killed because they didn't, you think about it. I wonder how many of those people didn't even know what they were doing, Erica, right? Like they had no idea why they were wandering off. Suddenly had this fear that they've never had before, right? And, just think about it. Some of the other stuff that happened as well with mustard gas and stuff like that. It just amazes me the stuff that we didn't know then that we know now. But even now, it's still frowned upon for you to report head injuries in the military, which we're going to talk about all that in a little bit with how some of that comes into play. But these are kind of the most common presenting symptoms. Headache is the most common. Well, gee, right? That makes sense. What is the medical term for headache? Because you may see it reported as that in the patient's chart, and you want to make sure that you understand what the medical term for headache is. What's the root for head? The prefix for head. Yeah, so cephalgia, right? Cephalgia is the medical term for headache, right? And I love when I have patients come into the clinic and they're like, I've got cephalgia. Congratulations, you read your chart and you know that you have a headache. It's nothing special, it's just a headache. I mean, it is kind of special because it's damaged, but it's not like you've got, you know, Parkinson's. Difficulty concentrating is another big one. Fatigue, drowsiness, dizziness, foggy, feeling slowed down, light sensitivity, balance problems are really common. And then just difficulty with memory and difficulty with memory are really common. So like these are the true kind of cluster of things we can have. We already talked about headache. Nausea and vomiting are really common. And that's mainly because of the, you know, oftentimes cerebellum being kind of messed up. Sensitivity to light. Some of you that get migraines know this, right? You get that migraine and, oh boy, turn out all the lights, let me live in the dark. Numbness, tingling, dazed, stunned. Cognitive, always, the term that you hear a lot is they just feel foggy. Right? I just feel like I'm not myself. Forgetful of recent information, which is common. Confusion about recent events. Answers questions slowly. And we're going to talk about with athletes doing a baseline testing. And we'll talk about how that's good and bad. Emotional, irritable, sad, more emotional, nervous. They can be pseudobulbar affect, everything to that effect. Sleeping more than normal. Why do you think if you have a head injury, you might sleep more than you normally do? What do you think's going on? Yeah, the brain's trying to heal. The brain says, I need this rest. Well, sometimes it doesn't need as much rest as it's requiring, and you end up with sleeping way too long. So when you get a patient that presents with TBIs, well, they can have decreased level of consciousness, obviously. Cognitive defects, motor deficits, sensory deficits, communication deficits, behavioral deficits, and associated problems. One of the things the PT is going to have to kind of tease out with this is, what's the patient's baseline? Because let's add a curveball in here. Let's say that we have a patient that has long-term Down syndrome. Are they already probably going to have some cognitive and motor deficits to start with? Yeah, right, Kelly? They're going to definitely have some cognitive and motor deficits. So now if the PT just goes, oh, well, these are obviously caused by the traumatic brain injury. Well, no, they have to go, okay, what was the patient's baseline? It's going to be really difficult in the outpatient clinic to determine because you may never have seen this patient before and you don't have a baseline to go off of. And that was kind of where we existed in sports before too, was that we didn't have a baseline to go off of. So we just kind of played it by ear and it didn't work out that well. Secondary complication that can occur to this, increased intracranial pressure, ICP, right? This is not talking about the juggalos, right? It's not talking about the insane clown posse. This is talking about increased intracranial pressure, right? Thank you, Jaira. At least somebody got that. If you don't know who the juggalos are, after you're done with this lesson, go Google the juggalos. Whoop, whoop. You might lose all faith for humanity. I'm just saying. Anoxic injuries. Again, that brain will start pruning off those areas and you may end up with an area that just doesn't get oxygen. Seizures. One study linked epilepsy rates at 85% with one TBI. Think about that. They're saying that you have about an 85% chance of getting a seizure disorder just from getting a single traumatic brain injury. And I know a lot of the athletes that I've worked sideline with, I've had a bunch of them where they'll say, well, yeah, I went home and I was sitting at home and suddenly I looked up and it was an hour later. So what do you think happened? They probably had an absent seizure. Yeah, they probably had an absent seizure. And it's difficult. Now, it could also be they fell asleep, right? That's always a possibility as well. That happened to me, that happens to me way too often now that I'm getting older, that I just suddenly fall asleep. Communication impairments are really common. So speech impairments, Wernicke's aphasia, Broca's aphasia. Dysautonomia is the big one. We're going to talk about that with a couple of the athletes. So dysautonomia, what does that mean? So difficulty with driving a car, autonomia. No, it's not driving a car. How about if I say, yes, dysautonomic nervous system? How about that? Right? Dysautonomia means that basically they're having problems regulating all their normal unconscious body processes. So heart rate, rest rate, blood pressure. I've seen athletes come off the field with a traumatic brain injury and have, 250 over 120 blood pressure that didn't have a history of high blood pressure. Right? For some reason, the heart is literally just squeezing itself to death. DVTs are common. Again, where are you most likely to get DVTs? What area of the body? Or where they're likely to develop? The legs, what specific area of the leg? The calf. Good job. Heterotrophic ossification. What does that mean again? We talked about that last class. Heterotrophic ossification. Bone growing muscles, right? Yeah, bone growing where bone shouldn't be, right? I've actually seen somebody where they've gotten that nice noggin shot where they get that big old honking goose egg on their forehead, and they've actually had bone growing in that. So all that can happen. Pressure injuries are really common with these patients. And you'll find, again, if you get somebody that's got a long-term brain injury that's in an LTAC, that's a real common reason for them to die, along with pneumonia. Chronic pain, right? I just hurt, doc. I don't know what to tell you. Good thing here. What if your patient keeps calling you doc as a PTA? Because I've had it happen. Yes, correct them, please. Right? You guys aren't docs. Now, what if they call you a therapist? That was a doorbell. That was me. Let me go see who it is real quick. Hold on one second. Pause just real quick. They cut my water line. Fantastic. Yeah, no. It's great. That's where you went. It's fantastic. Yeah, so here's the thing. Now, some PTs are going to flat out tell you you're not therapists. I did a poll with PTs that are out there and said, How many of you feel PTAs are therapists? And about 85% said, we are both therapists. And then you get about 15% that'll say, you guys aren't therapists, you're therapist assistants. So just be careful when somebody says that. If your PT doesn't like it, correct them. It's not really something that's going to harm something. Calling you doc, yeah, that can be an insult to not only doctors, but the PTs and everything else like that. So just correct that one. Sorry, that just happened to pop in my brain as we're going through it. Contractures, decreased endurance, muscle atrophy, fractures, peripheral nerve damage, all of that can kind of occur with this. So how do we rate these patients? Well, first of all, when they come in, especially if they've had severe loss of consciousness, we're going to rate them on the Glasgow scale, right? So Glasgow scale is going to be somebody that is not thoroughly 100% cognitively there, right? They're a very low mental functioning patient at that point. Oftentimes they're in a coma or in a veg state or something to that effect. So the scores for the Glasgow scale are going to range from 3 being the worst to 15 being the best. One thing I want you guys to take away from this, whether we're talking about the Glasgow scale or whether we're going to be talking about the level of cognitive functioning scale, both of those scales, the lowest number is the worst, the higher number is best. That's about what you specifically need to know about them. Now, for Glasgow, it's important to know the divisions. So 3 to 8, so about to 8 is severe, to 12, moderate, and then above 12 is mild. So this is where we're going to run through specific testing here. So if you look, the lowest score anyone can get is 3. Right? So if you ever get a question on your boards that says, what is the lowest score a patient can score on the Glasgow Coma Scale? The lowest they can score is 3. So a patient that is a 3 has no response at all with eye opening, no verbal response, no motor response. That means they are completely and utterly not present, right? They have checked out. They are off on another plane at that given moment. So we're going to look for eye opening problems. So spontaneously, what does spontaneously mean? Well, that means you walk into the room, you don't necessarily announce your, yes, absolutely, we will do, absolutely, we will do Glasgow scale measurements on patients. So I'm kind of going over them with you. So a spontaneous eye opening would be that you walk into that room and they open their eyes. Now, all of us have that feeling, right? Do you ever have that time when you're laying there in bed and your eyes are closed and your significant other might have walked into the room and you get that feeling like somebody's in the room? And so you kind of snap awake, right? Or maybe it's a home invasion. I don't know. Hopefully not. We just can't diagnose it. Exactly. We will do the follow-up testing for it. We won't diagnose them with it. Oftentimes, the first diagnosis isn't even done by PT. It's done by a doc in the ER or emergency department. I've got to get used to calling it that and not calling it an ER because we don't give them rooms anymore. So you walk in, patient opens their eyes. Now, you walk in, nothing happens. You get no thing. The next thing you're going to do is you're going to call out to them. You're like, hey, Kelly, how are you doing today? And now Kelly opens her eyes. She gets a 3. She doesn't open her eyes. The next step we're going to move to is, will she open her eyes if we cause her pain? So the 2 different ways that we do it, we talked about before, the sternal rub, where you take your big knuckle here and you just rub it vigorously right up and down the sternum. It's like, I will fight you. And then the other one that we can do is taking your fingernail, usually of the thumb, placing it down on their nail bed and squeezing down. And they actually now have a little tool that you can use that basically is a pair, looks like a pair of clippers to me, but doesn't actually clip into their nail. It just kind of causes it to get squeezed. If she kind of opens her eyes to the pain, then she gets 2 points. If she get no response, that's a 1. That's as far as we go with that. Verbal response, you know, you're fine, Javen. Just hang out as much as you can. Verbal response. If you go into the room and the patient is oriented to time, place, and person, that is going to be the best scenario. So they get a full 5 points for that. This is where it gets a little weird with this one, because I think this they need to kind of schedule this one out a little bit more. Because if they're confused about any of those, they're considered confused and they only get 4 points. I mean, sometimes you're just not sure where you are, so you lose a point for that. Right, so now you come in and you're like, hi, Kelly, you know, how are you doing? Oh, okay. Where are you right now? I am on the moon. Look at those Martians. Oh, Kelly's confused. Right? And she was the one to respond to me, so she's now going to be my TBI patient. Inappropriate words, right? Now, this can be anything. There can be some, right? So she's actually saying something, but she's not getting full words out of it. They're not completely, you know, or I've had it where I've gone in, I'm like, so how are you feeling today? And all of a sudden, yes, I was going to say that would be the other thing. They just start cussing profusely. Absolutely. I've had it where we used to call that, it'll make a sailor blush, right? They're just absolutely off the handle with cussing. Right now, you come in to see if you can get any verbal response, and all you get is, that's inappropriate or incomprehensible sounds. So they still get points for that. Look, she gets 2 for that, right? Best motor response. Now we're gonna what kind of motor response could you ask them to do? What's the most common, do you think? What do you see a lot when you're watching somebody, like when you're watching Grey's Anatomy and they've got somebody in a coma? What do they always want them to do? Move toes. Yeah, that's a little harder, actually, believe it or not. Squeeze my hand. Do you ever see that when the family's sitting there like, I think he squeezed my hand. He's obviously got, you know, he's there. Ma'am, he's missing his head. Just kidding. Not that way. Yeah, usually squeeze hands or move the arm is kind of what we're looking for. So if they obey command, if you're like, okay, can you squeeze my fingers, please? And there we go. Great. Now, here's something interesting. You may get no eye-opening response. You may get incomprehensible or no verbal response at all, but suddenly get a motor response. That means something's working up there, but maybe the processing's not working. Right? So, hey, you take what you get. Squeeze his hands, great. Now, remember when you did that little pain rub? If you do that pain rub and Kelly kind of shrugs away from you, that's moves to localized pain. And that's part of the reason why we're now squeezing the fingers, because we want to see how she moves. If she just at least moves, she gets 5. Great. But if when you cause pain, you get a flexion withdrawal, what would a flexion withdrawal look like? That type of motion, right? You get a flexion withdrawal, they get 4. Now, this is where you have to be trained in this, because there's flexion withdrawal and there's abnormal flexion or decorticate posturing. So flexion withdrawal is they kind of flex up and they go back. A decorticate posturing, you will literally see both arms kind of go in like this, like they're playing the Easter Bunny, right? What I want you guys to think about when we talk about decorticate and decerebrate posturing. Decorticate, they are pulling to the core. Does that make sense? So decorticate, pulling to the core. Decerebrate has an E. So they are doing an extension response. They move away from the core. Decerebrate posturing is worse than decorticate posturing. Because when you think about it, decorticate posturing is protection. It's a response, a protective response, right? We had that as babies, right? Decerebrate posturing means you have actually regressed so much that your integrated fetal reflexes have de-integrated. And you're now not having any protective response whatsoever. And so when you get decerebrate posturing, you're going to extend back, right? So decorticate posturing, what you're going to look, so looking like at the upper body, right? I'm going to get flexion of the wrist, flexion of my fingers, flexion of my elbow. I'm going to get shoulder abduction and horizontal abduction. So what posture does this kind of look like? Yeah, bunny, okay. Jail posture, fetal posture, right? It's almost going back to fetal standings, right? When you see a baby laying in bed, a lot of times they're in a decorticate, they're in a position of protection, right? That's why babies lay that way. They're in a position of protection. They bring everything to the core to protect the core, because the core is what's going to keep them alive. Does that make sense? Now, one of the things that's different about baby posture versus decorticate posturing is whether it's decorticate or decerebrate, the legs are going to go into extension. So we're not going to rate decorticate and decerebrate posture over what the legs do, because in both posturing, the legs are going to extend back. So we're going to watch the upper extremities, right? So decorticate, you come in like this is what I want you to think about. Now, what do you think decerebrate posturing is? If you had to be logical about it. Decerebrate posturing is just the exact opposite.
Okay, I found this on the web for what posturing is just the exact.
Thank you, Siri. No, don't respond. She's helping me. Yes, so decerebrate posturing. So this is one of the ways I remembered this when I was in school. Look at this. What is this again? This is which pattern? D1, right? What I always remembered in school was decorticate is D1 flexion, almost. Decerebrate is D1 extension. Do you see how that can help you a little bit? Now, it doesn't mean that the wrist positions are 100% exactly like the ulnar deviation, radial deviation. That doesn't really matter. But what does matter is kind of the general posturing, right? So if I'm in decerebrate, my fingers are going to open and splay. My wrist is going to extend. I'm going to slightly abduct and horizontally abduct the shoulder, and I'm going to extend the elbow and shoulder. So I'm way back here like this. A lot of times if you have somebody that goes into decerebrate posturing, they'll push off the bed because they're completely kind of extending. So the main thing to take away from this is decorticate, again, is a flexion posture. Decerebrate is an extension posture. Why do you think I keep repeating this? Other than it's probably going to be on my test. Yes, this is huge on the national exam. Understanding the difference between decerebrate and decorticate and understanding which is worse and which is better. I have a video a little bit later coming up. Yes, there's another. Decerebrate has a lot of E's in it, so it's extension. I have a video coming up where it's a football game and the player gets hit and gets concussed. And instantly, as soon as he gets concussed, he goes into decorticate posturing. What does that tell you about it? I'll answer your question in a second, Dylan. If he got hit and he's automatically gone, yeah, that's bad. Now, if you've gone into extension posturing, which I have seen on the field, that's worse, right? So Dylan asked, is the response always both arms? Yes, it is a bilateral response. That's why when we talk about that flexion withdrawal from pain, it's usually unilateral. So if you cause them a little bit of pain or scratch them in the arm, then it's just usually a single arm flexion. If you get decorticate, Dylan, it's both arms that pull together. Decerebrate is worse than decorticate. Always remember that. Decerebrate, worse than decorticate. Decerebrate, worse than decorticate. So extension, worse than flexion. in this case, right, for this specific deal. And if you get no response, that's the absolute dead worst. No response means the brain's not responding at all, right? You see no response, no response, no response. The brain has checked out at that point. Now, the bad part is when you have somebody that's really that low in the Glasgow Coma Scale, that's a bad sign. Typically, it means they're not going to come out of it. I remember when my mom had her seizure and she went in, one of the first things they ran was the Glasgow Coma Scale on her. And the neurologist that came in and ran it, he's like, she's a 3 on the scale. The likelihood she has any brain activity at all is pretty low. So that's how closely this actually relates to how the brain is affected, right? Just by doing that simple Glasgow Coma Scale and getting no response, the neurologist was like, she probably doesn't have any brain activity. I'm sorry to tell you that. And you got to think about that. That's kind of a hard thing to tell a family. So does everyone fairly well understand the Glasgow Coma Scale? All right. So now we're going to talk about another scale. We're going to talk about the Ranchos Los Amigos Level of Cognitive Functioning Scale. Most times when you see this, it's going to be abbreviated RLA-LCFS. You guys have encountered RLA before, right? You countered it with gait. Again, we've talked about this before, is because the Ranchos Los Amigos research is mainly in neurological function. So now you're starting to get better on that Glasgow Coma Scale. The next thing they're going to classify you on is the LCFS. They're going to look at how much is going on in the brain. So once we get out of that initial phase of injury, what's going on up there? Same thing as before. The higher the rating, the better the patient. The lower the rating, the worse the patient. In this case, the scale goes from 1 to 8. Now, you're going to ask me as we go through this, Mr. McKeever, how much of this do I have to know for my boards? And I'm going to tell you, yes. You have to understand, not only do you have to understand if it says RLA 1, LCFS 1, do you have to understand that LCFS 1 is no response? You also have to be able to integrate that. And we're going to talk about integrating some of these ideas when we look at the patient scenario for this. So level 1, patient's got no response, does not respond to external stimuli. Patient may appear that they're asleep, right? So at that point, they're still in that either vegetative state or coma state. Level 2, they're starting to get generalized response. They're also starting to move up the GCS, the Glasgow Coma Scale. Reacts to external stimuli in non-specific, inconsistent, and non-specific, non-purposeful manners. Right? So this maybe they swing at you or something like that when you're trying to move them around. Level 3, you've now got a localized response. The patient responds specifically, but inconsistently with delays to stimuli, but may follow some simple commands. So maybe ask them to squeeze your fingers and they squeeze your fingers. But it may be inconsistent. You ask them again to squeeze your fingers and they move their toes. So level 1s, levels 2s, and level 3s are probably your most difficult to get therapy units out of because they're not exactly the most appropriate for therapy, right? Because who's going to do all the work for level 1 through 3? Who do you think is going to do all the work for a patient that's level 1 through 3 in the PT or the PTA, right? You're going to move them. You're going to be tossing them around. You're going to do all the work. It is a laborious and sweaty job to work with a patient that's got a TBI that's level 1 through 3. Because most of the times, especially when you get to level 3, they start fighting you. And now you got to not only fight moving them, but you got to fight them fighting you. Yeah. Now, here's where we start getting to our fun patients. So now the patient's starting to come out of that kind of stupor. They're starting to become more cognitively there, but level 4 is a confused, agitated patient. Patient exhibits bizarre, non-purposeful, incoherent, or inappropriate behaviors, has no short-term recall, attention is short and non-selective. Some of you are going, hey, that's me. I exist at level 4 all the time. So let's think about this for a second. We have a confused, agitated patient. What are they going to act like when you come in to see them? Are they going to be happy to see you? Yeah, they're going to be aggressive. They're not going to be happy to see you, right? This is going to be a rough go. We have to treat them even at this level. So that means you have to become the biggest cheerleader in the entire world. Because you're going to ask them to sit up in bed, and maybe you're lucky and the patient does sit up in bed, but because they're still in this confused state, they sit up, and when they sit up, they immediately lay down. And the patient knows he was supposed to sit up, but unfortunately the body just didn't work the way he wanted it to. So now he's getting mad. And whose fault is it that he laid down? In the patient's mind, you think? Yeah, you. You caused them to do this, right? If the patient like this falls, you're at fault for their fall, even though in reality, we are kind of at fault for that, right? But to the patient's mind, you caused it. Let's say you see him on Monday, you're off on Tuesday, and you come back on Wednesday, and the patient's still at that scale. And you go in and you say, hey, do you remember me from Monday? What's the patient probably going to say? Nope. I don't know who you are. Right? Or, oh yeah. I've had patients where they're like, oh yeah, you're that girl that I met at the bar. What? Right? These patients can be really fun to deal with, but they can also be an amazing struggle. What I will say about treating traumatic brain injuries is it can be extremely rewarding to see them, to move through the stages. It can also be extremely frustrating because they can get stuck in phases. And I've had patients stuck at level 4 for weeks to months. If they're stuck at level 4, are they going to be appropriate to go home? No, not at all. Right? These patients are also going to be the fun ones that take their gowns off in the middle of therapy. That can be fun. Like, these patients are essentially little bratty kids, is a good way to think of them. Not that all kids are bratty, but just most. And I treat kids, so I can say that. They just react not appropriately to everything you ask them to do, right? I've had it where I've gotten the patient up and I've gotten them up into the jerry chair so I can turn around and grab something. And in that 2 seconds that I turned around, all of a sudden they're flinging their gown at me and they're naked as a jaybird. And then you're trying to put the gown back on them and they're fighting them. I don't want this gown. I like this. No, right? Let's talk treatment area. Levels 1s, levels 2s, level 3s, and levels 4s. Where do you want to treat them? What type of environment? You're going to treat them in the hospital, good. But what type of environment in the hospital do you want to treat them in? Closed environment, in their room. Now I'm going to show you, so let's think about this. So now I've got a massive TBI and I'm level 4, and you take me up to an open environment. So remember, open environment means there's lots of stuff going on. Not necessarily open as in everything's clearing out of your way. Remember that when we're talking about environments, when we're talking about physical therapy, right? You may be thinking open as everything out of the way. Absolutely, everything should be out of the way. But an open environment is basically like the shopping mall. You wouldn't want to take this patient to the shopping mall. It's not going to go well. They're going to be running through the shopping mall, naked as a jaybird, saying inappropriate words. Now, that may make great YouTube videos. It's not going to be good for the patient, right? So closed environment for kind of levels 1 through 4. That also includes turning off the television, turning off any music, right? You need to get this patient focused on you and what they're doing. Otherwise, even something as simple as, I don't know, Nicki Minaj coming across the radio is enough to throw him into a complete tizzy and mess things up. So you want to make sure the environment is kind of closed off to what they're doing. Now we move from level 4 to level 5. Now the patient's starting to get a little bit better. Now they're confused. They're still doing inappropriate things, but they're not agitated with you anymore. So they're no longer an angry patient. They're still confused. These patients now start getting a little more fun. The patient gives random, fragmented, and non-purposeful responses to complex or unstructured stimuli. So the harder the task you give them, the more inappropriate their response to you is going to be. So if you are very specific and very simple with what you have them do, they're usually able to complete it, right? I often liken these patients to about a third grader, right? You can keep the third grader on task for a few minutes, but if the third grader sees a shiny bike, all of a sudden the third grader's off. Right? So simple things, sit to stands, transfers to the chairs, maybe some very, very basic walking back and forth in an area. Now we can start introducing stimuli at about a level 5. The stimuli you want to start introducing is familiar stimuli. So what kind of stuff might you introduce that would be familiar to the patient? What kind of stuff do you think? Favorite music works out well. So, you know, probably for me, you wouldn't want necessarily playing Slipknot. It probably would not be a good idea, right? Because that might put me in the agitated response at that point. But something like that, if you know that the patient likes classical music, maybe add a little bit of classical music. If you know that I like hard rock and heavy metal, maybe add some, but necessarily maybe not the hardest stuff in the whole wide world, right? Maybe you know they like Jeopardy. Well, put some Jeopardy on. If you know they have a favorite family member, grindcore, exactly. You know that they have a favorite family member. It might be beneficial to have them in the room with you at that point, because you're starting to introduce normalized stimuli to the patient, right? I would still keep this patient in a closed environment, but you can start opening it up to different materials, right? Maybe not move everything out of the way so they have to think through some stuff. They're still going to take their gowns off. They're still going to, in this stage here, usually, this is where they're going to start grabbing you in places they're not supposed to grab you. I've had more grabs and inappropriate hugs than you can imagine at level 5s, right? I've been put on some patients that, you know, are male and are level 5s that were with a female therapist quite a bit because they just decided to get inappropriate with them, right? So this is, you have to be careful here a little bit, but you can get through these level 5s. Level 6 are getting a little bit better. Now we've got some confused appropriate. So now they're responding to you. They're doing things that they're supposed to do. They're still a little confused, right? So the patient's giving context appropriate, goal directed responses, depending on external input for direction. So they may be able to stand up, but they need your guidance to stand up. They don't do it on their own, right? There is some carryover at this point. So now we can start adding in. Do you remember yesterday when we worked on sit to stands? Okay, we're going to do that again. But they're not going to remember stuff that we haven't covered with them, right? They're not going to be, this is not going to be the point where the patient remembers what they did yesterday or what they did this morning. They remember what they did yesterday, but they won't remember what they did this morning. A lot of times at this level, now OT is starting to come in. You can start adding in at level 5, Renee. You can start adding it at 5. Now, level 6 is going to be the best place to start adding more of it. Does that make sense? Because now they're starting to get a little bit more appropriate in the response. Level 6, you're also going to start seeing OT doing memory games with them. And when I say memory games, literally, guess what they're probably playing? Memory. You remember that game as a kid where you have the little cards with the people and you're like, does your person have blonde hair? No. Click, 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 click. Right? Because what you're trying to do is get that cognitive stuff going. Now we're at level 7, automatic appropriate. Now the patient's starting to get almost ready to go home. Right? And at level 7, you can probably start thinking about sending them home. They behave in an appropriate, familiar setting. They perform daily routines automatically. They show carryover. And learning just a little bit slower. The patient does start interacting with social interactions, but judgment remains impaired. So they're definitely not going to want to go to the casino, right? But now they're starting to get into this daily routine. At level 6, I start writing a daily schedule up on our boards for them. So they have a schedule. At level 7, I'm now starting to have them write their schedule so that I can kind of get that routine going with them. And what you're going to find with TBIs is the more routine you give them, the better they're going to react to you, right? Judgment is still going to be impaired. You may still occasionally get them saying something inappropriate, right? I've had a level 7 where I take them up to the gym and, you know, they'll see somebody with an amputation and they're like, well, that must suck to have your leg blown off. Okay, let's use that as a learning experience, right? Or they'll, you know, they'll get up from the mat when they shouldn't get up from the mat. So you've got to be constantly watching. Any of these TBIs, gait belts have to be on them. You have to be with them. You cannot let them sit by themselves. They will get up. They will fall. Now, level 8 is where we definitely are good to send home. Level 8, we've got purposeful, appropriate responses, patients-oriented, response to the environment, but abstract reasoning skills are decreased relative to premorbid levels. So now at this point, they're almost back to where they are, but they still have those moments where they're just not 100% what they used to be. Now we're starting to talk about sending them home, right? When we're looking at these scales, usually, and I'm just going to say, I'm adding usually here, levels 1, 2, 3, and 4 are most times in the inpatient acute care, so hospital level. Sometimes level 4s will get sent out to rehab. Send a level 4 out to rehab usually doesn't end the best. You know, 5, 6, 7, now we're talking inpatient rehab. And then 8, we can start thinking about home. Does that make sense? All right, so I fried you a little bit here. Let me pause recording, resume recording. So we're back to this. We're talking, last thing we talked about was cognitive functioning scale. Are there any questions on the LCFS? So whereabouts do you think you're going to start using terms like, do you remember, and stuff like that? Where do you think you'll start remembering, or start saying that? About level 6. That's when you start using terms. Do you remember when we did this yesterday? Do you remember this? So before that, you need to wipe that out of your vocabulary, right? And that can be really difficult to do stuff like that. Again, levels 4 and under are definitely single room cohort treatments. They're in the room with them, no one around, everything off, everything quiet. And so that's when we start kind of adding stuff as we go up. Whereabouts do you think you'd want to be before you take a patient up to the gym? What level? Okay, we can start thinking about it at 5. Better is about 6. We can start thinking about it at 5, definitely. 7 will be perfect. Absolutely, so can it. At 7, they should be going to the gym. Because at 7, we should start adding an open environment to them. And of course, like I said, 8, we're starting to send them home. Even at 8, though, are they still going to require caregiver support? And that may be lifetime. So that's one of the things we have to kind of talk about with these patients is you may need help for the rest of your life. Now, this is an interesting thing. how many TBIs would it take until they start having these symptoms? How many TBIs does it take to go to a level 1 on an RLA scale? What do you think? What's the minimum number for them to start? Yeah, just 1. How many TBIs take to charge a light bulb? I love it, Erica. Yep, that is. Right. It can be just a single TBI can lead them to having permanent cognitive deficits. Now, we've learned over time that this is interesting that we've now starting to realize is we used to think that one bad TBI is worse than multiple mild TBIs. We now actually know that in the long run, multiple head injuries, whether they're mild, moderate, or severe, are worse than a single severe head injury. So that repetitive trauma we know is worse for the brain than just a single really bad incident. So what do we do in PT? Well, just like we talked about already with all of those disorders, you know, Parkinson's, MG, MS, all that. Initial intervention are focused on safety, energy conservation, return to function. One of the things you're going to have to remember about these patients is most of the patients, I'm going to use the term most, are going to be 25 and under that have TBIs. Why are they going to be 25 and under? What's so special about 25 and under people? Yeah, active lifestyle, though, you know, I'll challenge you that we can have active lifestyles after 25, but those are also more likely to have the hold your beer moments, right? Your frontal cortex isn't fully developed till you're about 25, right? Also, usually about 25, what do you start having? Typically, as long as you're not somebody that was before that, family. So what happens to risk-taking behavior when you start having to care for somebody else? Usually, risk-taking behavior goes down because now you're taking care of somebody else. And yeah, under 25, they do suck at driving. You're exactly right, Kelly, typically. Although I will challenge that over 65 often as well. Exactly. That's why when you get married, supposedly your car insurance goes down, right? I guarantee you, though, I'm going to tell you something, Erica. When you stop being married, your car insurance goes back up. I don't know if you realize that or not. It's not very much fun, especially if you're male. The car insurance goes way back up. So just because I was married, my car insurance is cheaper. But yeah, so, you know, when we're starting off on these, so we have two different classifications. We have 25 and under, and then we have 65 and older, or another large area of TBIs. Why is 65 and older do you think we're going to start encountering them again? False. Exactly. Right? So that's kind of, those are our two kind of cool groups that we have. The 25 and under group, 65 and older. Now, it doesn't mean somebody from 25 to 65 can't get a TBI. Absolutely they can. It's just those are our clusters of people. So what are we going to do? We talked about safety, energy conservation, return to function. We're going to work on that. Prevent contractures. If they're in the hospital and they're down in those low levels of function, we're going to be coming in and doing range of motion. We're going to be teaching the families range of motion, right? We're going to be helping to roll the patient, move the patient, maybe get them up into a standing frame, get them up into a tilt table. The goal is to prevent especially pressure injuries. Because you saw that little post that I sent out about Christopher Reeves, right? Christopher Reeves, who played Superman, died from a pressure injury. Think about that. Like, literally, how insane is that? Yeah, it does make you sad, right? Superman died from a bed sore. Right? Like, it wasn't kryptonite, it was a bed sore. Heterotrophic ossification, again, passive range of motion, making sure we're moving them around can help prevent some of that. If it's going to happen, it's going to happen. And then we're going to have to treat it with the way we treat it with, either doing, you know, iontophoresis or phonophoresis to help break it down a little bit. Reflex inhibiting postures. We're going to put them in positions that If they're in a posture that is more extensor oriented, what kind of posture do you think we're going to put them in? So let's say they're decerebrate. We're going to try to go opposite and put them into flexion posture. If they're in a flexion posture, what do you think posturing we're going to try to put them in when they're laying down? We're going to try to go extension, right? So that we're just going to try to reverse whatever problem they have. Now, one of the common things at the legs that's going to happen is whether we have decerebrate or decorticate, they're going to be extremely plantar flexed. So what muscles are going to tighten up if they're extremely plantar flexed? The calf, right? So we may actually be doing stuff like putting them in splints where we splint them into dorsiflexion so that they don't get permanently stuck in that plantar flex kind of that dancer type pose. We'll increase patient awareness. There's a lot of studies that have shown talking to your patient, even when they're in those low levels where you think they're not listening to you, does amazing things. And we talk to patients' families about this, right? They'll come in and maybe the patient's in a coma. We tell them to talk to the patient. Because if we do an fMRI, when a family member is talking to a patient, it actually shows that the patient is actually listening, even if they're not 100% cognitively there. That's pretty cool to me, right? Because that means the brain is working even if the brain's kind of shut off. The brain's saying, hey, I am acknowledging somebody's out there talking to me. Now, does that bring everyone out of a coma? No, it doesn't. Some people will exist in a coma forever. Can absolutely play a movie, yeah, right? If their favorite movie is Jurassic Park, it's time to watch some dinosaurs destroy some things, right? Their favorite movies are Godzilla series, time to watch some Godzilla series. The people that evidently I worked with are all violent action films. No one ever wants to watch like My Girl or something like that. So that also goes on to sensory stimulation, right? Giving them stuff, even if they're in a cognitive fugue, to stimulate their senses. But then once we get to that confused state and that agitated state, we've got to be careful stimulating senses, right? We want to have some positive stimulation, maybe not so much some aggravating stimulation. Work on cognitive functioning. What kind of stuff can you do with a patient what kind of stuff can you do cognitively with a patient while you're treating them to help kind of start working that brain? Math works, yep. Talking also works. Just having them tell you a story, right? I've done it before. I'll tell them, hey, tell me a story about when you were young. Yeah, talk about family, right? Tell me about your godson. Tell me about your son. Tell me about your nephew. Anything we can do to get that brain going. Now, you have to be careful because some of these patients are going to be in that can't chew bubblegum and walk at the same time phase. So you'll ask them to tell you about their son, and what do you think is going to happen? They're going to stop. And they'll start talking to you. You have to go, okay, let's talk about it while you're walking. Right? So you have to kind of get them doing that. And then patient and family education. And this can be, again, another one of those rough ones because sometimes the family just doesn't realize how much work it's going to be to get their loved one back to normal. And sometimes you tell people that, and all of a sudden it's exit stage left. I've actually seen it before where, specifically in the military, where, it's not a military spouse, right? But it's the soon to be spouse, right? Soon to get base housing assistance. And their significant other comes back, has severe traumatic brain injury. And I've actually seen it where the doc starts talking to him, and we're talking to, in this case, it was a young lady, about what she's going to have to kind of help us with getting him back to normal. And she says, okay, great. Listening. She's like, okay, I'm going to go use the restroom. And she never came back. Yeah. Just walked out, never came back. Try to call her, the phone's now disconnected. It is kind of messed up. You're exactly right. And that's only because I think there's a little bit of human nature in that. even though we don't want to admit it, because we don't want to be responsible for another person's life. Even though we have kids and we're responsible, the kids are a little different, right? We don't want to be responsible for another adult's life. We just don't. And so, you know, right, they don't understand what they signed up for here, because that's part of it, right? That's why part of the marriage clause is in sickness and in health till death do us part, right? Although we can get into a whole nother social theory on whether marriage is actually good for society or not, but we're not going to do that. That's a whole nother cognitive trail we could get on for a couple hours with Mr. McKeever here. We're not going to do that. But it's, you know, people will say till death do us part, or, you know, in sickness and health, until that sickness happens. And then it's like, oh, this stuff just got real really quick. And that can be really rough for some people. Now, some people handle it like a champ. They just are like, okay, what do you want me to do? You want me to transfer them out to the chair every day? Let's do it. But a lot of times that'll change, because over time they'll go from being a significant other to being a caregiver. And that structurally changes the relationship. And then eventually sometimes that can lead to the relationship ending as well. So it's a rough go. I don't ever want to say it's not. Even, you know, even like a mother, we're going to talk, like Christopher Reeve's wife was the ideal case. I mean, we're going to talk about him a little bit in spinal cord injuries, and you'll see she's like rock star. I have no other way of putting it. She is a rock star when it came to taking care of him. But it just doesn't work that way, right? And you got to imagine that, you know, even you guys, and you think about this right now, you guys have emotional needs. And if you're in a relationship, you expect those emotional needs to be met and taken care of. Well, now if you can't have them taken care of because you're taking care of physically another person, you know, that can be rough. I'm just saying, it is rough, right? All right. So one of the assessments we might do is the BESS. The BESS is the Balanced Error Score System test. And this is just to see how bad that TBI is going on up in the head. It also can be used to diagnose vestibular issues, which we'll talk about later. So what you're going to have the patient do, again, this is going to be, they're not going to be until we're up into the at least the 5 level now, preferably 6, 7 level that we're going to test these patients. But this is a really common one for sideline assessments for, you know, in athletes who's been injured. Because if you look, so we're doing a total of about 8 things, right? Yeah. 8 things, and we're doing them for about 20 seconds each, right? So you're talking less than a 5-minute assessment. And this can tell if this person's pretty messed up. So we're going to do double leg stance on a firm surface. So they're just going to stand on the ground and stand with their feet together for, you know, 20 seconds. Then they're going to do single leg stance. Then they're going to do tandem stance. So what is tandem stance again? Tandem stance is, it's staggered. It's one foot kind of in front of the other. A lot of times it's called Romberg, right? We have Romberg and we have sharpened Romberg. Romberg's going to be the easier two, where you just kind of have the feet like this. Sharpened Romberg's where they're like this, you know, heel to toe. Either of those is valid. I usually tend to do just regular kind of tandem, because that sharpened tandem can get a little rough. And then you're going to put them on a foam surface. Now, what happens if you don't have a foam surface? What if you don't have an AirX pad or a Dynadisc? What can you use? Towels? Yep. Pillow. Yeah, every hospital room has a pillow. Use a pillow. Right? So it doesn't have to necessarily be foam, because we've had this, you know, if you're on the sideline, you'll do one on maybe like the track surface and then one on the grass. But if you're on the sideline, typically we have an AirX pad somewhere around there, right? And I've done a little bit of sideline work, so I will talk a little bit about that. This is the NFL Sideline Assessment. I have the actual version of this up on Blackboard for you to take a peek at. But this basically gives us a baseline stat. So if you're an athlete, one of the things we're going to talk about in the NCAA, one of the things we're going to do when you come in as an athlete, so you come in as a student athlete, you're going to see a trainer, PT or a PTA. And we're going to do these tests with you, even though you're healthy, because what we want is a baseline. Because what if you just have crappy balance? And now you come over to me after we think you've had a concussion and you're still crappy. I might think you have a concussion when in reality, what it is your balance just sucks. So we need a baseline to go off of, right? So what will happen here with this NFL Sideline Assessment, and some of the colleges have adapted this as well, they'll do this as soon as they become an athlete. And then they keep that on file so they can compare it to if the patient gets an injury to the brain. So in the inpatient acute care setting, we're going to do positioning, wheelchair propulsion, range of motion, improving awareness, family education, functional training, a lot of sitting activities, especially in those 5 and under. We're going to do a lot of sitting at the edge of the bed, a lot of sitting and reaching, right? So sitting in front of them, hands on the gait belt. Okay, I want you to touch this shoulder. Okay, I want you to touch this shoulder, right? Remember that anytime you take that hand off the gait belt, you are setting the patient up to fall. So please be thoughtful of that. Transfer, standing activity, treatment planning, and then physical environment training, right? Make the room a little bit less exciting at the beginning and then add more as the patient progresses. We can add stuff like incorporating cognitive components. Ambulating while in a conversation is big, right? Ambulating while moving their head. Now we're adding different vestibular stuff as well. Simulating environments such as a grocery store. A lot of OT departments will have their little mini grocery store in one section of their thing. What it is designed for them to kind of get back to normal. A lot of them have the like home suite, right? Home sweet home. They get to walk around. There's an oven there. There's a washer and dryer. There's chairs. There's glasses. There's tables, in order to stimulate getting back to the home. And in family education, we do have to talk to them about outpatient therapy or community resources. There are always resources out there. And it doesn't matter what you decide to get into, right? So maybe one of you guys is interested in this, in working in TBIs. There are resources out there for these patients. Maybe you're interested in working with Parkinson's patients. There are resources out there. What I'm going to highly recommend is there are all kinds of organizations for each of these conditions. If this is something you're passionate in, start hooking up with those organizations as early as you can, because they will give you resources that you may not have had. You know, when I've worked with spinal cords and TBIs, I've gone to the National Spinal Cord Association. I've gone to the Traumatic Brain Injury Association, and they've gotten me things for patients that I would not have been able to get because of their insurance. I've gotten patients $35,000 wheelchairs that are in spinal cords for nothing, because that organization had a hookup with this company that was able to get this patient on a, on a donation, get their wheelchair. So you have to be able to, if you're going to be passionate about this, if you're just going to work in outpatient rehab, or outpatient therapy, still good to get in these organizations, but maybe you're just not a person that wants to get involved. Well, that's fine. We need you too. We need what I call, the bell clockers in my rehab facilities. The people that just come in, punch their clock and go home. But we also need people to get very passionate about this stuff. So adjunctive therapy, what other stuff can we add to them? Cognitive and behavioral impairments are important. So what kind of person are they going to see for cognitive and behavioral impairments? What type of clinician? Who deals with cognitive and behavioral stuff? OT a little bit, yep. And they're also probably a good idea to see a psychologist. Yeah. So that brings me to a good question. What's the difference between a psychiatrist and a psychologist? Does anyone know? Well, they actually both can give out meds now, Erica, believe it or not, as long as the meds are psych related. Yep. Psychologists can write med scripts too. One studies. They both are going to give you homework technically. There you go, a medical degree. That's the difference. A psychiatrist is a doctor that specializes in psychiatric disorders, so a medical doctor that specializes in it. The other typically focuses on the research side of psychology. A psychologist has a lot to do with research. Right now, there is another new degree out called the PsyD, which is also technically classified as a psychologist. The PsyD is basically the DPT for psychology. Rather than having to focus on going to school and doing all kinds of research, a PsyD is just a clinical doctorate, meaning they're trained to work in facilities, which is a really good, it's actually a really good degree. That, you know, you get a doctorate in psychology and you're working with patients and you don't have to do stupid research. Like one of the reasons why I don't have my PhD in psychology is because I don't want to do research. I have no interest in it. I hate research. I like working with research. I like being involved in it. I just don't like doing the paperwork side of research. That bores me. I know so many people that are working on research that are still stuck in the research phase and still don't have their doctorates because the research isn't done. So psychiatrist, medical doctor, psychologist, kind of psychological doctorate. One's a PhD, one's an MD. Disorientation needs to be worked with. Attention deficits, memory deficits, problem-solving deficits. All those can be worked on in OT. Behavioral and aggressive usually going to be psych, right? Motor deficits and interventions, they're going to see us, right? They're going to probably see PT for a good, probably 6 to 8 weeks minimum after getting out of the hospital even. So let's talk about a little bit about sports with TBIs. So this was gathered from 2009 to 2014, and this looked at percentages of sports that give students TBIs. Well, here's a big surprise. Look at this. Football is 35% of the traumatic brain injuries in sports, and I think that's underreported. Does that surprise anyone that football is the majority of it? What surprised me is the two next ones. Women's soccer and women's basketball are the two next largest categories. Now, soccer really doesn't surprise me all that much because I've seen a lot of, a lot of banging heads in soccer and falling on faces. Exactly, right? But basketball kind of surprised me. I don't know, like, because you got men's basketball and women's basketball and make up 18% of it. And then I was talking to some basketball players, like, you know how many times I've gotten elbowed in the face? And Renee's like, I got a concussion during a basketball game. Exactly. Right. And I didn't think too much about it because I don't know. I guess because I don't follow basketball too much, I don't think too much about it. Is there a lot of slapping the head? I evidently played the wrong form of basketball then. Or maybe just because I've never played basketball because I suck at it. That's probably really what it comes down to. All I know is orange ball goes in netting thing hoop. That's my extent of basketball. I'm done. They kept telling me I was traveling. I'm like, I'm not traveling. I'm going to the other end of the court. I'd be crossed out of my head. That's impressive. I don't have another word for it. The other thing that kind of surprised me is that wrestling is only 5%. I would have thought that wrestling would have been a larger percentage. But then I remembered they're on mats. That's part of it. Also, usually in the collegiate level, they have those soft helmets on, which give a little bit of cushioning, right? And the other thing is, it's not like you're doing, a suplex off the top ropes type wrestling. At most, you do a takedown and you're taught how to fall too, right? Women's ice hockey is up there. I don't think men's ice. this is another one I think is grossly underreported. But then I remember this is collegiate level. And collegiate level, you're not allowed to fight. Right? But this is kind of interesting. I mean, it just shows you that football is the majority of our things. So for those of you that understand football, and I apologize if you don't understand football, maybe you should learn. When do most traumatic brain injuries occur in football? Does anyone know? 2 specific plays. During the kickoff, good, and 1 other specific play. Wide receiver cross field, that's a close third. Punts. So special teams are where most of the traumatic brain injuries occur. So much so that the NCAA is considering doing away with both of them. I don't know. They're really considering, especially kickoffs, just doing away with kickoffs. Justin's like, that's how I got my. Yeah, I can't tell. I've got at least 2 of them from kickoffs. I got put on the kickoff team because I hit really hard. That's pretty much why I got put on the kickoff team, right? So kind of looking at this is kind of the NCAA's process. And I have to give the NCAA credit because the NCAA has been the reason why we started getting better rules in sports for head injuries. So in the early 90s, late 90s, they developed this thing called the Neurocog Testing. And we use Neurocog to this day. The Neurocog testing, if you've ever been, did any of you go to physical? I think I've asked this before. Did either of you guys, any of you guys go to physical for your clinical fill? I don't think any of you did. I think you're going for the second clinical fill. If you get a chance to go, the vestibular clinic for physical has a Neurocog machine. And it's basically this giant machine that you can simulate just about any environment in. Right? So they've got Neurocog testing. Late 99s, we developed that Tbis, which we talked about, and some better computer balance testing. In 2004, the NCAA didn't put out a statement, but the NATA did, the National Athletic Trainers Association. They put out a statement in 2004 stating, we have found conclusive linkage between head injuries and long-term deficits with athletes. So they came out, the NATA said, hey, we need to research this. Right? Thankfully, and here's the deal with, I don't know how much you guys know about this, but athletic trainers and PTs don't always get along the best. Right? There's a lot of competition there, especially on the sideline. But on the sideline, I'm nothing without a good athletic trainer. And a good athletic trainer, I think, is nothing without a good PT backup. Right? Because we're just going to get them through the acute phase and pass them off to the trainers. So I really like my athletic trainers. I really do. 2008, we're going to talk about the return to play criteria in a few seconds. So they came out with this return to play criteria. In 2008, they also came out with this thing called the Standardized Assessment of Concussion, or the SAC and the SAC-2 they eventually did, right? Which gave us the ability to actually regulate the patient's concussions. 2010, NCAA enacted its concussion policy and started saying, hey, you need to monitor concussions. So at that point, they said to the actual colleges, you have to be regulating and monitoring how many concussions you have per year. 2012, another Zurich statement came out on CTE. And this was 2012. They said, well, it's not possible to determine the cause of CTE. But what we're going to do is they put this rule in place called the Dislodge helmet rule in the NCAA. And what the Dislodge helmet rule is if on the field your helmet comes off, you have to come off the field for at least 1 play and be assessed. Which is smart, because I can't tell you how many times before that, I see players, maybe they got a face mask and have their helmet pulled off, and they're still running down the field. The other thing it did was, if an athlete has the helmet pulled off, the play is blown dead right then. As soon as somebody loses the helmet, the play is blown dead. Well, that makes sense, because if you don't have a helmet on and you get tackled, you're pretty likely to get a concussion. 2013, they came out with probably the most controversial rule ever in NCAA football, the targeting rule. And I've got a great example of targeting coming up. But targeting basically is if you launch, meaning you forcibly leave your feet and launch at a player and strike them above the nipple level. So primarily up in the head, specifically leading with the crown of your helmet and strike their head, you are targeting the player. Does anyone know what happens in targeting? Yeah. It's a 15-yard penalty to start, and you're gone. And you're gone for 4 quarters of football. So not only are you out of whatever game you're in, but let's say it's the 4th quarter, you're gone for the next 3 quarters of the next game. And that can be huge, right? I think the NFL needs a targeting rule. I mean, they've gotten a little better about it with blows to the head, but I think this would be a thing that would stop that a little bit in the NFL as well. 2014, they started looking at the link between vestibular problems and concussions. 2015, they don't throw the player out. No, the only time the player is thrown out of football is they do disorderly conduct. Like if they hit the ref, if they start a fight, stuff like that, they can be thrown out. Now, I think there is a rule in now where if you have 3 blows to the head in the same game, you're ejected. 2 personal fouls. Now, thank you, Dylan. I knew there was something they added to it, but even that I think is, if you do one of those personal fouls, you should be gone. I'm sorry. When I say one of those, I'm talking about a targeting type personal foul. Now, you can get a personal foul where you do something stupid, and you smack somebody upside the head. That's not as bad as launching at them with your helmet. So there has to be a little bit of leeway here, right? 2015, they started putting concussion implants in helmets. And this is interesting. They found out in 2015 that this is amazing. They didn't realize this. But they found out when they have 2 players hitting each other at full speed, it's actually more force than 2 car impacts. And I can attest to this because back when I played football, back when we had leather helmets. No, we didn't actually have leather helmets. Back when I played football, I remember the team that we played against that everyone was terrified against was Steel High. And Steel High recruited all of the top athletes from the area. Like they were a Catholic run school and they recruited a lot of people from the area. And they were known for their football. They had big boys. I mean, most of their offensive line outweighed the defensive line by 50 more pounds. The big guys, just huge. But back when I played football, if you were big, you were strong. But nowadays, man, I don't know if you guys have watched any of like the NFL combines or even the players. And some of these people are 350 pounds and running a 4.7 40. Right? That's not a human being. That's a cruise missile. Right? Yeah, exactly, Jared, right? That is a cruise missile coming at you. Right? I think of the big one I always think of is Ray Lewis. Like just because he epitomized what you think of a linebacker in the NFL. The force that guy would impact the other players with would often, and you can see it in running backs. If you watch the Ravens ever play back in the day he was playing, they get hit once by him and they thought twice about going in that same area that he was in. And back when I played, that was encouraged, right? You wanted to be known as that enforcer that no one wanted to come near you. But we now know that's kind of dangerous. So here's the statement they released in 2010. The NCAA is committed to prevention, identification, evaluation, and management of concussions. Basically what we're saying is we're listening to you, parents. Latest step is to provide the development of consistent association and right approach to concussion management and has come from the NCAA Executive Committee. So here's what they said. All institutions must have a management file on plan or plan on file so that a student who exhibits symptoms or behaviors consistent with concussion shall be removed from practice and or competition. They have to actually be treated. Student athletes diagnosed with it should not return to activity for the remainder of the day. Medical clearance should not be determined by the team physician, or shall be determined by the team physician. That's changed recently. We'll talk about that. In addition, students, athletes must sign a statement which they accept responsibility for reporting their injuries. Think about that for a second. A student must sign a waiver saying they will report their further injuries. Yeah, Michelle's already laughing about that, right? Because they want to get back out in the field. Right. The other thing is the team physician voided it because team physician is going to be beholden to the coach. So a lot of teams are now getting independent physicians on their sideline. And the NCAA has started adding concussion monitors on the sideline, which are people that are not affiliated with the team, but are monitoring to see if people get pulled out of the game with concussions. And you can actually get fined from the NCAA for not doing things right. Right? So they initiated this return to play guidelines. It talked about functional stages, right? Student athlete may not progress to the next stage of recovery unless they've had 3 days without regression of symptoms. So when you're doing this, if you look at this, there's a total of 6 stages. It's going to take you 18 days to fully progress at minimum through a concussion protocol. So a little over 2 weeks. We know as physical therapists and physical therapist assistants now, 2 weeks is even too little for a traumatic brain injury, but at least is something. So if you have an increase in symptoms, let's say you've moved to stage 7 and you're having an increase in symptoms, you don't go back to the beginning of 7, you slide back to 6. You may slide all the way back to 1, depending upon how bad your symptoms are. So they have to be reporting their symptoms. But again, this puts it on the students to report all their symptoms, and they often don't want to report them. So stage 1 is no activity, complete physical and cognitive rest. This has to be for a minimum of 1 day. But usually it's 3, so they can't do anything for 1 to 3 days. Stage 2, now we start light aerobic activity, walking, swimming, stationary cycling, right? No resistive training. The object is just to increase their overall target heart rate. Stage 3, we start moving to sports-specific exercises, skating drills for ice hockey, running drills in soccer. No impact-related activities can occur. While we're doing there, we're starting to add activity and starting to add movement. Stage 4, non-contact drills. So we can start doing stuff like running routes as wide receivers, right? Hitting the sled, but not with our head in football. Soccer, we can start doing some, soccer-related cut drills, corner kicks, stuff like that. Basketball, now we can start doing up and down court drills. And in ice hockey, obviously, they put the puck in the net. You can also start resistive training at stage 4. Stage 5, now we start returning to cognitive practice or full contact practice. This is where a lot of players get stuck, because as soon as they return back and they get a mild contact, they'll have a relapse. Because again, it's not necessarily how bad their attack is, it's repetitive trauma to the head. And then stage 6 is obviously return to play. This was great and all. This was a fantastic move by the NCAA. I will give them full credit for that. But they forgot something here, because these are student athletes. So what did they forget about when they developed return to play criteria? Yeah, school. Exactly. So now they had to come back and they had to develop a return to academics platform. Because let's think about this, right? If an athlete is unable to perform on the field, why would we send them back to the classroom? Right? Think about that just for a second. We're saying that the athlete is their brain is messed up so bad, but we'll send them back to calculus. No athletes taking calculus. Well, maybe a few. Very few of them. We'll send them back to basket weaving. Or if you actually, if you ever actually see what some of the football players get degrees in, it's kind of sad. But Yeah, so why would we think, yeah, it's not a good idea to send them back to the classroom, right? So they should be held out of class as well if they're held out of sports. They still have to complete their work. They still have to do everything like that, but it's just they're going to be delayed on it. So they developed a return to academics plan, which is developed in a return to play, right? The guidelines assume that both physical and cognitive activities require brain energy utilization. That makes sense. We have to use our brain for everything. And after a sports-related concussion, brain energy may not be available for cognition. That makes sense too, right? So as with return to learn, is the first step is just cognitive rest. So for about a day or two, they're going to be out of doing anything. And then we're going to start minimizing cognitive stressors, right? So a lot of times these athletes, one of the things that they have to be taken away, that has to be taken away from them is video games. I know that some of you are going to get really upset about that, but if you have a traumatic brain injury, you should not be playing video games. There's a ton of research on the cognitive load that video games put on your brain. And that can actually, it is a lot, right? And that can actively affect you, right? And you've got to think about this, and I'm just going to generalize here, but most 18 to 25-year-old guys in a college dorm aren't playing Bejeweled, right? They're not playing Peggle. They're not even playing, you know, they're not playing Among Us or what's the other one? Fall Guys, right? They're typically playing violent, aggressive games. And that triggers a lot to your brain. And that can even trigger a PTSD event, right? Maybe your character or whatever experienced an explosion. Well, that can cause cognitive dissonance. So we need to let them off in that. Reading can be a problem. Doom 6 is definitely out. Yeah, even Modern Warfare is probably out, right? There's a huge study out that shows that benefit of cognitive rest on recovery. So if we let them rest their brain a little bit, cognition gets better. Consideration should be avoiding the classroom for at least the same day as a sports-related injury occurs, right? So if they're injured on a Saturday, probably should not return until at least Tuesday to the classroom. Now, a lot of student athletes will say, I've still got a concussion, so I can't go back to class. Well, that's great. Then you can't return to the field either. Right? So there has to be a little bit of tie-in between the field and school. So as the NCAA modified its thought process, so did a lot of the other organizations, right? We're going to finish on this slide and then take a break. So despite this evolution, some schools still underreport their TBIs, right? There's one school that's local to us. I won't mention what they are, but they might be in the Western Conference. That in 2018-2019 football season, they reported 0 concussions for their whole football program. Does that sound right? The football, not a single football player on their team for basically 2 years got a concussion. Yeah, absolutely not. There is no way. They must suck really bad. Yeah, this would be one of those cases where the NCAA then said, you know what, that's fine. And for the next football season, guess what they did? They sent in auditors. And they found out the school was underreporting. And unfortunately, when that happens, they'll hit them in the pocketbooks. They'll hit them in their scholarships. Right? So there's less scholarship money available for those student athletes, which means then their teams get worse, usually. As with I'm tongue-tied today. As with most things, the training typically spreads downward. So the NCAA developed it. It's starting to move down into the high school fields now, where high schools are starting to take TBIs more seriously. And it makes sense. If you take these concussions seriously, then your players will have longer careers. And if you're a student athlete, if you're a high school athlete, you want to become a college athlete. If you're a college athlete, you want to become a pro athlete, right? That's kind of what your whole dream is. Trust me, I know that was the whole dream of playing sports, is eventually to go pro. What percentage of players actually goes pro in any league, whether it's NFL, NBA, any of those? What percentage of high school athletes? Does anyone know? Yeah, less than 1% of high school athletes go professional, and then less than 4% from college to professional. Right, so it's not a, you know, it's not going to be one of those where it's a high percentage of them are going professional. But if you can manage your TBIs, you have a greater chance of going professional, right? If you get really bad TBIs and you're out of college, you'll never go pro. So the NFL starting to come around a little bit on this, and they're starting to track head injuries. They still don't provide long-term care to their athletes that are out of football, though, for head injuries. The NHL, this is the NHL statement. There is no clinical link between repetitive head trauma and long-term detrimental effects. I think the MMA is probably the worst. Head injuries are part of the sport, and athletes know what they're getting into when they step in the octagon. Yeah. Oh my God. Right? So let's take a break here. We'll start finishing up here. So I'm going to stop my sharing. So let's take a 10-minute break and we'll go get some caffeine, go to the bathroom, and we'll talk through this here a little bit more. So last we left, we talked about the different types of areas that are, you know, different people that are doing, they're studying these. There we go. My brain's working. Brain worked good. So let's look at this here. So the NFL, when they started tracking concussions, they had over 200 a year. And again, honestly, if you talk to most medical experts, they're saying this is probably half of the actual amount of concussions that happened. So in 2012, 261, 2014, we went down, 2019, we, you know, at 224. Now this season is going to be interesting. I'm curious to see what the concussion levels are going to be on this season, because it may be different because of this whole COVID thing. I'm not sure. The NFL also designed this committee to kind of look at traumatic brain injuries, right? In 1994. So he put this guy in, Dr. Elliott. And if any of you saw the movie Concussion, Dr. Elliot Pellman was in that movie. He was the guy that was fighting the coroner about this, right? So 2002, this is the doctor that's in Concussion, Dr. Bennett Omalu. He's a forensic pathologist. He was a forensic pathologist for Pittsburgh, right? He's the co-founder of the Brain Injury Research Institute now in California. He identified CTE, which is basically the brain melting in former brain of Pittsburgh Steelers center Mike Webster, who committed suicide. He's the first person to ever identify CTE in American players. So we got a whole different thing here. So right after that, the NFL meets with Dr. Omalu and says that after sustaining concussion, it does not leave significant risk for secondary injury in the same game or during the season. So then Dr. Omalu finds it in Terry Long and Andre Waters, both who had committed suicide. Well, then in 2007, Dr. Pellman's like, yep, I'm out, because it was pretty much proven that at that point, we're starting to link concussions to traumatic brain injury in the long run. 2007, they hold another conference on concussions where they find no link to long-term effects from concussions. But we're going to go ahead and form a concussion guidelines, which included a telephone hotline to report if players feel that they've got a concussion and we're not taken off the field. That's going to help. Right? In 2009, they had the House Judiciary Committee. So this is how bad it got. Think about this for a second. The House Judiciary Committee held a hearing on head injuries in the NFL. Congress held a hearing about football injuries to the head in football. Yeah, right? That's just like crazy. 2010, they had another one, part 2 of the committee, right? And the NFL denies a link between repetitive head impact and long-term damage. As you can see, the leagues don't want to admit that this is a problem. Why do they not want to admit this is a problem? What happens if they admit it? It means they've lied to players all this time. And that also is going to open them up to what? Lawsuits. 2010, they renamed the Mild Traumatic Brain Injury Committee to the Head, Neck, and Spine Committee. Right, 2010 again, Goodell issued a memo that said all 32 teams wants possible suspension for offenders that violate playing rules that unreasonably put the player at risk. Basically saying that if the team knows the player's got a head injury, then they need to be pulled out of the game or they're going to get fined by the NFL. Another player commits suicide at 50, researched. They find that he has same CTE disease that all the other players have had. Ray Easterling commits suicide. They find CTE in him. Junior Seau commits suicide. They find CTE in him. Right? Then the NFL players file a unified lawsuit saying, hey, we need this taken. The NFL files a motion to dismiss the concussion-related lawsuits by former players. The NFL still says, no link. So much so that the National Institutes of Health step in. And they commit $30 million to support research on medical conditions prominent in athletes. And then the National Institute of Health steps in and says, yeah, you know how you said the Junior Seau's brain didn't have CTE? It had CTE. Junior Seau's family files a wrongful death suit against the NFL, right? The NFL reaches a settlement with the ex-players to pay $765 million to fund medical exams, concussion-related compensation, blah, 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 to a case that now has 4,500 former players as plaintiffs. Like, this just shows you how crazy it is. 2013, they exhumed Jovan Belcher and test his brain. Guess what? CTE. He shot his girlfriend to death and then killed his own self because he heard she was talking about him when she wasn't talking about him. 2014, they finally approved the settlement. Instead of $765, they only get $760. The real sad part about it is the lawyers got a lot of it. Yeah, the League of Denial is a great thing to watch. You're exactly right. That's another great one to watch. 2014, Dan Marino steps in and sues the NFL, and other players join him. Now, this is the first time it gets real for the NFL. Why do you think it got real when Dan Marino filed it for it? Does anyone know football, why that's so important? Yes. Before that, it had just been a lot of players that the NFL quoted as no-name players. So much so that in June, look what the NFL does. The NFL works with Marino and he withdraws his name from the lawsuit. What did they threaten him with? They threatened pulling him from all broadcasting. Yeah, right? Former NFL players, Ballard and Westbrook file suits. So we keep getting more and more of these suits. And so this is interesting that in 2015, federal judge gives final approval of the class action lawsuits between the NFL and thousands of former players, approves $5 million per retired player. Hooey, that's a lot of money. And then, so in 2015, it was interesting. The same day that Frank Gifford's family files a lawsuit saying he suffered from CTE, at that point, the quarterback for the St. Louis Rams, Case Keenum, played after having a head injury on the field. And I don't know if any of you saw that game, but twice he ran to the wrong sideline. And they kept him in. Kenny Stabler dies of colon cancer, but he's diagnosed with CTE in 2016. Senior NFL official finally publicly acknowledges a connection between football and CTE. And they start looking into it, right? I love this. They want to know what it is, and they say that the answer is definitely the question is there's certainly a yes that there's some link between head injury and long-term effects, right? So we've studied, they've come through a bunch of different players. I'm not going to go through all of this here. In 2019, this is where it gets important. In 2019, the NFL announces a total of $3 million has been made to the NFL's helmet challenge. And they're developing new helmets for players. And there are some really interesting helmets that came out of this. And there's a lot of them that are currently being tested in the league that have been shown to reduce impact by up to 50%. The NFL is finally now, you know, how many years later saying, okay, maybe we need to do something about this, right? It still doesn't fix the problem. And here's the deal. They're never going to take all of this out of football, right? That would pretty much structurally change the game if we took impact out of football. That's not what football is. And that's not what the players want. If you talk to the people that are playing football, that are in these lawsuits, they don't want all contact taken out of football, but they want the NFL to acknowledge that if people lay down their lives for 15 years for a league, they should have health coverage for the rest of their life. It just seems like a fair exchange, wouldn't you think? You know, with all the money that the NFL makes, it's $100 billion a year that the NFL makes. So that's where we come to this CTE. Right. And this is kind of what I've been researching a lot lately. Chronic traumatic encephalopathy. It's a tauopathy, right? And tau are protein that are naturally occurring in your body. Taus help clean up areas that have damage, right? What they found out is prior exposure to repetitive head impacts, even mild ones, can lead to this condition called CTE. Prior to recently, the only way we could diagnose CTE is by posthumous brain dissection and looking at splices of the brain. Interestingly enough, we now are able to actually detect these levels of tau protein in blood and plasma, CSF. So blood plasma and CSF. So we're now able to look at this and go, okay, maybe we can start seeing players that have increased levels of this exome communicator, this tau protein, are more likely to develop later in life CTE. I've had lots and lots and lots. I'm triple digits levels of concussions. I was talking to a friend that I went to play football with back in high school, and he was talking. So, do you remember that game where you got your bell rung so many times in the game? He goes, and you just really weren't even making sense on the sidelines. I'm like, no, I don't remember that game. I don't like that. I remember that weekend. I lost that whole weekend because of a head injury, right? So the neurologist I was seeing in Vegas here, I went and he drew the tau proteins. Amazingly enough, I have positive tau proteins in my blood, which means that I have a risk later in life of developing CTE. There have been a lot of studies have shown ways you can avoid advanced onset CTE is by keeping your brain active, doing, functional stuff. But the problem is you can't eventually avoid it. It's going to happen. If you've had repetitive trauma to the brain, you're eventually probably going to develop CTE. So let's just look. This is just a few athletes that we've lost to CTE. And let's look. What I want you to focus on here is their method of death, right? So here we have Michael Webster. 50 years old. He was kind of the case that started this all. Heart attack from drug intoxication. Andrea Waters, 44, self-inflicted gunshot wound. Kevin Turner, advanced ALS at 45, basically, or at 40, he developed ALS. 46, he died. Junior Seau, self-inflicted gunshot wound. Bubba Smith, acute drug intoxication. Paul Oliver at 29, self-inflicted gunshot wound. Terry Long, drank antifreeze, died. Tom Keating, advanced prostate cancer. And after posthumous and search of his body, not only did they find CTE, but they found cancer pretty much everywhere in his body. Chris Henry fell from the bed of a pickup truck, struck his head mildly, and died. Literally, they said he bumped his head and died from it. So I started Paul Oliver and Kevin Turner because those two, when they did a research on the brain, specifically Paul Oliver, when they looked at his brain, they broke it apart, and they said that his brain looked like he was 150 years old at 29. That's kind of terrifying. Kevin Turner, they said he was in his 90s in his brain. Right? That's terrifying. But what I'm looking at here is look at all these people that killed themselves. So I don't want to leave it only to NFL. Let's look at the NHL. Bob Probert, 45. Advanced heart failure with no previous signs of heart problems and no family history of heart problems. Reggie Fleming, he had a stroke and a heart attack at the same time. Interestingly enough, his son said at the time of his death, he had less than 3 seconds worth of memory. Essentially had the memory of a fly. Jeff Parker, lung heart failure combined. His lungs and his heart stopped at the same time. Steve Montador is usually the one that a lot of people remember from hockey. He had sudden respiratory and heart failure. He laid down. He said he had a headache. He laid down. His heart and his lungs stopped. 7 days after his death, his son was born. Derek Bogard, acute drug intoxication. Todd Ewan, self-inflicted gunshot wounds. Andrew Carroll jumped 7 stories off of a parking garage at Chicago O'Hare International Airport to kill himself. Kyle Rarup was another one. His brain at 20 years old looked like he was 100 and some odd years old. Self-inflicted gunshot wound. MLB, Ryan Friel is pretty much the poster child for CTE and MLB because the MLB is another company that says, well, we just don't get head injuries in Major League Baseball. And yeah, they do. Specifically catchers and those people that slide into base a lot get head injuries. Yep, absolutely. There's a lot of linking to, so Kelly asked if you have the tau protein, can also mean you get Alzheimer's later in life. It can, yeah. I mean, tau protein is an early sign of Alzheimer's, but it doesn't necessarily mean you're going to get Alzheimer's, if that makes sense. X Games, Dave Muir, 41, self-inflicted gunshot wound. The one that scared me the most when we looked down, like pro wrestling and MMA, Chris Benoit was probably the scariest one. At 40, he strangled his wife and 7-year-old son before he hung himself. And he did that because the voices told him to do it. And the year before or whatever, he had come back into wrestling and gotten something like 14 concussions and kept wrestling. Tess Martin, acute drug intoxication. Ashley Massaro, female wrestler, acute drug intoxication. Jimmy Superfly Snuka died from rapid onset stomach cancer. Literally, his cancer went from 0 to 60 in 1 year. Rapid onset diabetic coma for King Kong Bundy. And then Jordan Parsons from the MMA, he got an acute septic infection that he should have been able to fight off, but his brain didn't fight it off. That's kind of terrifying. This is an interesting slide here. So on the right, we have a normal brain. On the left, we have Steve Montator's brain from the NHL. This is at 35. Both of those, it's a 35-year-old brain on the right, or on the left. On the right is Steve Montator's brain. Do you see a problem there? Yeah, the brain has basically pruned itself off, hasn't it? Yeah, I've seen the Aaron Hernandez special. It's just about, yeah. There's a lot in showing that, you know, his problems that he had was related to CTE, right? Like everything he did can be tracked back to all his head injuries. And he had a lot of head injuries in college. Like a lot of head injuries in college. Like this brain just blows my mind. Look at that central sulcus here. Look at that. There's the natural V pattern. His is a U. Right? Look at your ventricles, right? That's what they should look like. Isn't that crazy? Like, this kind of stuff terrifies me, knowing how many concussions I've had. So here's Greg Pletz. Greg Pletz only ever played college level. He was part of the 1969 University of Texas Longhorns undefeated team, which is still held up to one of the best defenses ever in college football. So the top brain is a normal 66-year-old's brain. The bottom brain is his brain. I mean, if you didn't know better, you'd almost think this is a Halloween cutout. It just shows you what this does to the brain, right? So this is kind of looking at what we remember from the neurons and stuff like that. The tau protein interacts out here, right? So we have our cell body. There's our little dendrites out there. We have our axon that goes away, right? The tau proteins act out here on those end bulbs of the axons. And what they do is they create these things called amyloid plaques. And they'll scar over the ends of these axons. Now, where they meet the dendrites for the other nerves, now there's no communication, so that dendrite gets melted away. And slowly but surely, the body will just completely prune off this nerve. And it'll keep pruning off all these nerves that are experiencing that until there's huge areas of the brain that are basically melted away. And it's kind of looking at what the actual tau protein looks like. This is what a diseased neuron looks like. See how the healthy neuron's all kind of pretty and has nice, shiny, fatty outside area for the transmission. You look down here, you got pock marks all throughout it. So this can lead to things like early onset Alzheimer's. It can lead to things like, you know, early onset dementia, Parkinson's disease, everything. And it's like I said, now we're starting to see that it actually can lead to things like ALS, which to me is, you think about that stuff, it's kind of terrifying. I have a couple different films in here for you guys to watch through. The only one I really want to talk about, there's a great video here. Let me stop share real quick. There's a great video in here from Danny Carcillo that I want to share. So Danny Carcillo played with Steve Montador back, I believe, on the Blackhawks, if I'm not correct. It's been a while since I watched this video. But I'm going to play the video for you guys. And one of the things I want you to kind of look at is look at his progression of his mind and his face as he progresses through time. Share screen. I got to remember to share the sound. All right, let's make it full screen. So let me know if you can't hear this. Chat. There's chat. Okay. Where's my volume at? There's my volume.
I met Steve Montador in Chicago. I think it was 2011. I had a couple surgeries, and I had a problem after those surgeries with I abused pills with my recovery, and had a really hard time getting over it on my own. But Steve was a huge help and in kind of leading a sober life. I think the reason that we were so close is because we had a sorry. Before I came to Chicago, I had a reputation of that I like to have fun, and I think a lot of the guys were surprised when I got here that I said I wasn't drinking anymore, and I think it made it a lot easier for me knowing that Monty was here too and kind of on the same program. You didn't feel like you had to lie to him and say, "Oh, I'm doing okay," if you weren't. Through our friendship, we had Monty went through some really trying times. And I got to see it firsthand. That lockout year, he'd suffered a concussion and the team had put him on waivers. and he didn't take it very well. I think he was really worried about the future. Over the years, I saw kind of that deterioration of his mind, and he must have, felt that as well. Just recently going home to Mississauga and to his home and seeing the number of sets of keys he had for, the same lock, kind of tells you the story of what was going on in his head, and his memory loss and his mental state, because he was trying so many things to kind of reverse the symptoms or feel normal, and he just couldn't. And he had a lot going on in his head in regards to worrying about whether he'd wake up that morning and feel great, or whether he'd have to stay inside with the blinds shut in a dark room. When you have a concussion, you go through that. It's a dark place. I just recently had one, and I fell into a lull and a depression, especially after Monty's passing. After Monty died, I really did some research and kind of asking guys that had already moved on and that I'd played with, and asking them if they knew what our exit program was for the NHLPA. And I was kind of astonished to find out that not one guy could tell me what it was. Right now, as far as the PA goes, we would receive a phone call to kind of see how we were doing, and that's pretty much our exit program. And from the guys that I've talked to who've moved on, they've all said the same thing. We all fell into kind of a deep depression, and that they went away quietly. It was almost as if the less noise you make when you go away, the better. I don't think it's right. It doesn't feel right for how much we give to this league and to this sport in regards to sacrificing our bodies, sacrificing our minds with concussions and the hits that we take. Obviously, everybody knew about Monty's passing, and I had a really hard time with it. I wasn't myself, and one of the guys who reached out to me and on a regular basis was Jonathan Taves, and Sharpie too, and it meant a lot, to be in such a dark place emotionally, and then to have them care, and those are guys that Monty would love to have in his life. When I think about that, a big reason why I'm kind of summoned the courage to do this, because my hope is that it helps somebody, and it opens the right eyes, and people get in contact with our PA, or people get in touch with each other, and we can try and create something that's going to help athletes figure out what they're good at and what they want to do next in life. And I know Steve this past year was trying to figure that out, and I wish he had, because I think it would have eased his mind, and I think if he had the right help, that he would still be here with us. And
so the reason I did that, so did you guys notice his thought process as he was talking? Did you see him kind of reaching for words a lot? Right? Very slow and very kind of pause, and then, oh yeah, this is what I wanted to say. So this was right after he retired from the NHL. He had to think about what he was going to say a lot. And so initially the NHL said the reason he looked that way was because he was emotional about Monty's death. That was why he was the way he was. So the reason I wanted to kind of show you, because now, or nervous, right? Now I want to show you a video from about, I think I want to say it's 18 months later. after he's done some therapy. Let me bring this video up real quick.
This tracker is amazing.
I don't care about the tracker. Go away, ad. All right. I don't want to try out a YouTube whatever either. So now watch the difference, and look even at the difference in his face, his facial muscles, and everything when you see this new video of him. Same player.
It's scary. Like, what's the point? What's the point of playing professional sports? And it's supposed to be for the memories, you know. And you can't remember that anymore. It's really scary. We're in Florida, Orlando, Florida. I'm getting personal treatment for the head traumas that I sustained while playing in the NHL. I needed to come here because my speech was being slurred every month or every week, every day that went by. The sun hurt my eyes more and more. I was having headaches, problems sleeping, more mood swings, depression, anxiety. Flip a coin the night before I went to bed, and I wouldn't know how I'd wake up the next morning. It's not an easy proposition for a man with pride and ego to come here and assess the state of my brain, especially with a 3.5-year-old son, a year-old daughter, and another daughter on the way. The quality of life that repetitive traumatic brain injuries rob from you is, I would give back all of my money. I would give back all of the time. You can take my name off the Stanley Cup twice over. I can't live like that anymore. You know, I just can't.
This is really working to kind of recalibrate your brain's perception of how you stand and how you occupy each space.
Alzheimer's, dementia, Parkinson's disease, you're 80% more likely to contract those three diseases if you have 3 or more concussions. That's fucking scary. I'd be scared if I was still playing the NHL, if I was Sidney Crosby, if I was any one of those young kids. I wish that I had been given the information that was withheld from me while I played in the NHL. And I can't lay my head on the bed when I see injustice and I see people being treated in the same manner as my friend Steve Monitor had been treated. I'm the type of person that when I see injustice, I need to act. And I need to hold people accountable. The truth. Tell the fucking truth. The people who are running the NHL and the NHLPA right now need to step up and take care of the best athletes in the world, the best hockey players in the world. Build a brain plasticity center, and if an NHL player gets hurt, send him there. You'll get a better athlete back. You'll have less man games lost, and everybody wins. There's no way that an athletic therapist or an orthopedic surgeon should be touching our heads. In my experience, they cannot properly diagnose a traumatic brain injury, and they cannot properly build you a program accordingly to make new neurological pathways around those dead neurons. This is how you treat it. This is how it's diagnosed, and this is real treatment. And hopefully this can circumvent early onset dementia, early onset Alzheimer's, Parkinson's disease, The stats aren't flattering. The research isn't flattering. But I think if you have hope and you do the work, that you can stave that off. I believe that. I don't want somebody else to be in this position. You have a lot more years to live after professional sports, and starting to feel like myself again, and my personality's coming back. I'm able to sleep. My sensitivity to light has vanished. Yeah, I fought. And I played the game very hard. And yes, I gave out many traumatic brain injuries. I also sustained many. My son is 3.5 years old right now. He'll see my fight videos on YouTube, but he'll also see these player tribute videos. And hopefully that will educate him in the risks of the job that I did. No, I don't love the NHL. I love the game of hockey.
Did you guys see a different player there? Or a different person even? Yeah, like even his, like what struck me was his facial structure even. Right, in that first video, his face was just sunken. And it was evident that he wasn't sleeping, he wasn't eating, he wasn't taking care of himself. Right? And again, credit to him, it was his significant other, his wife, that basically laid her foot down and said, no, you're either going to take care of yourself or you're gone. That's it. Because his mood swings and his violence and stuff like that got really out of hand. So he came out and he's got a plan. So that's Danny Carcillo. You can find him on Twitter. He's all over the place for that. He's got a brand called Ducky Brand right now, which is actually a really cool brand. They're developing like clothing and stuff like that. And all of the proceeds for that brand go to research concussions for NHL players, which is actually really cool. But as soon as he started coming out on this, what do you think the NHL did? What do you think they did to him? Well, not even, they tried to take it down and then they smeared him. They went after him hardcore. They didn't even try and pay him off. What they did was they put out videos showing him dishing out concussions and saying basically, how dare he talk about concussions when he's the one been giving them out all his years. They blamed him for giving other people concussions, saying that he has no right to talk about them now. And then recently he's been working with that Neuroplasticity Center in Florida and bringing more athletes down. And they're finding out, oh my God, all these athletes have repetitive head trauma. And so now they're going back and saying, well, look, he said some really racist things in his past. And so obviously you shouldn't listen to him. Yeah, they're basically, it's exactly right. They're trying to cancel him. They really are. And I just saw there was a whole back and forth with him with Paul Bissonnette because they played together in the Canadian Hockey League. And, you know, Bissonnette's another one that was kind of a talker and kind of a thug on the ice. And he said, well, you know, if you knew the real Danny Carcillo, you know that he mouthed off to people, he used bad words, blah, 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 blah. My question to that is, how much of that was actually Carcillo being that way and how much of it was his traumatic brain injuries? Right? How much of that was that repetitive trauma that caused him to act that way? And not only that, but, you know, think about it, even the NFL, because a couple of those videos are on the NFL hits and stuff like that. In the NFL, what are the majority of the videos the NFL puts out on YouTube and stuff like that? Is it, you know, the greatest blocking done by an offensive lineman? No, it's the biggest hits videos, right? The hardest hits videos. If you look at all those videos, the NHL, it's all the fight videos. They encourage that type of kind of barbaricism in the sport, right? And think about it, if you go to a hockey game, what are most fans going to the hockey game to see? Yeah, fights. Right? That's what it's the sad truth of it. Right? They're not going to see somebody shoot a one-timer from center ice, right? Although that's kind of cool when it happens. They want to have players that are, down and dirty and getting with it. But we now know like the trauma that comes from this, right? The Canadian Hockey League starting to take this seriously. I will give them credit. They are working with Carcillo and they're working with a couple of the other players. Gretzky's also been working with them on this. That they're putting together a Neurocog center in Toronto where they can send players that have been concussed to get proper diagnoses. But I think one of the things he said in that, other than the tell the truth, he used a little bit more colorful words than just tell the truth, was that if they send those athletes to these centers that are specialized in neuro, they'll get a better player back, right? And I thought one of his comments that struck me is an athletic trainer, an orthopedic surgeon shouldn't be the one to diagnose a head injury. And that makes sense, right? We're not gonna, I'm gonna use gynecology here as an example. We're not going to trust a neurologist to diagnose a gynecological problem. They go specialized for specific reasons, right? That makes sense to me. I don't know, it kind of makes sense to me. I know a couple of you sent me messages saying this really kind of makes you want to get into this field of researching and learning how this works, right? What you'll find really quickly is while the players that are out of the league are all for this, the players that are in the league oftentimes deny any of this. And there's a couple reasons for that. Obviously, because we're young, we're dumb, and, we want to say this can't happen to us, right? But the other thing is the players that are actively in the league and come out in defense of this stuff oftentimes get excommunicated, right? The leagues are really good at excommunicating people that don't carry the company line. Right? You can see that not only in just head injuries, but look what happened to Eric Reed and Colin Kaepernick for standing up against, racial injustice. Both of them don't have jobs. It's amazing what the league can do to these players because they hold all the cards. And it was interesting that there's a great book. I highly, highly, highly recommend it. It's about Steve Monitor. It's called Game Change. Literally, I picked that book up and I read it in about 2 nights. It was, to me, that interesting to read through. But he got a really bad head injury and wasn't himself. So what does the team do? The team doesn't get him help. They put him on waivers. Basically, cut him from the team because he had a head injury. I don't know. That seems really callous to me. I don't know how it feels to you guys, but that seems really, really callous to me. Like that'd be like you guys, one of you gets a C or something like that. And I'm like, well, you're not going to make it through the program. So why don't you go see what the basket weaving group has for you? Right? It's kind of scary. Let me see if there's any of those other videos that I definitely want to show you. There's the NHL's denial incidents there. So one more quick video, and then we'll look at the case study here real quick. Copy. So share screen again. So this is a football video, and this just shows you how quickly a head injury can occur. So this is Nebraska versus Ohio State, and this, I want to say this was 7 years ago. Don't quote me on it. Is anyone in here an Ohio State fan? Because I'm sorry if you are. Just joking. So let me make sure is this high quality? It's high quality, okay. Watch what happens to the quarterback here.
Kicks around the edge, gets the first down at the 25-yard line. So
One of the scrambles, and Armstrong's down after getting knocked down by Hooker. Oh, boy. He is not moving there.
Must have been where he got hit, didn't have a chance because of the way he was holding the ball to brace himself.
Lee Hooker took his feet out from under him.
See how the ball's in his right hand. He doesn't get a chance really to get his head, protect his head there. It's like his head may have hit the ground.
Definitely did.
See the ball in the right hand? Just doesn't have a chance to brace himself.
Boy, it's just an awful scene. He's still laying motionless. And prayers now.
So the reason Eric's like, holy crap. So the reason I show that, and the reason I asked if any of you are Buckeyes fans here, if you've ever been to Buckeye Stadium, the field itself is AstroTurf. Once you get past the white line on the sidelines, it's concrete. And it's just got a layer of basically fake grass over concrete. So that whole sideline where they're standing is just a layer about that thick of fake grass over concrete. So when he went down like that, his head literally just crushed into concrete. Does anyone know what his NFL career was like? Tommy Armstrong from Nebraska. Never had an NFL career. Played like 2 more games in college level. At one time before that injury right there, he was predicted to be a first-round draft pick. But the side effects he suffered from that concussion pretty much ruled him out from playing. That just, it's terrifying to me. That stuff. And a lot of these players, so now a lot of these, so like Danny Carcillo and a lot of the NFL players that are suffering from this, if you ask them if their kids will play the same sport they do, what do you think their answer is? Think Carcillo's going to let his kid play hockey? Yeah, probably not. And he said at the end, he loves the sport of hockey. He doesn't love the NHL, right? So maybe pub league, stuff like that, he might let his kid play hockey, but I don't think he's going to let him play professionally like he did. And it's becoming less and less. It used to be when I grew up, back in the Stone Ages, you would watch, a dad play football, and then, 10 years later, you'd see the son come through the same football. It's not happening as much anymore. You don't have legacy football families anymore like you used to have. Right? I often think of, with the Raiders right now having Derek Carr as their quarterback, Derek's bigger brother used to play football for Houston. Right? And he also played, I think, for a while with the Giants. But unfortunately, when he played for Houston, Houston didn't have an offensive line, and he was the most sacked quarterback for like 5 years in a row. And he's out of the league now and has massive brain injuries. So I got to imagine, I can't imagine what Derek Carr's got to be thinking about playing football and knowing that his brother's as messed up as he is. But you can see, even if you watch some of the NFL games and the NHL games, and you see the players that are announcers now, you see how their cognitive ability is going downhill quickly. Terry Bradshaw is an excellent example, and they're now broadcasting his home show too, which I don't even understand. But he's an excellent example. If you actually listen to him talk, over the past 5 or 6 years, his cognitive ability has just been going downhill like crazy. So let's look at a patient that has a TBI real quick, a patient scenario here. Let me find it. That is not the TBI. I think it's patient scenario 4. No, it's not 4. It's not 5, is it 3? Much of B1. There we go. All right, so let's look at a scenario here, and then we'll end for the day. Kind of same idea we looked at with the other patient here. So now we've got a patient here. So we got Richard Grayson. He's a 25-year-old male who's 3 weeks post-acute fall from a high height with an anterior coup counter coup injury. And he's in a rehab facility with you. Can everyone see the screen? Did I make it big enough that it's pretty clear? Okay. So let's look at his active concerns. So he's RLA level 6. So is he still a little bit agitated at 6? Do you remember? I know we just covered that. Yeah, he's still a little bit agitated. He's got decreased visual acuity, right? So he had a coup counter coup with anterior posterior. That makes sense. He's got decreased vision, right? Because his backside's affected. He's got occasional incidents of Wernicke's aphasia, decreased functional static and dynamic seated balance, decreased functional static and dynamic standing balance. He has positive Babinski signs. We'll talk about that in a second. Poor bilateral, non-equilibrial reciprocal fluidity. What? So it says poor bilateral upper extremity, non-equilibrium reciprocal fluidity. What that says is his upper extremities are not moving in conjunction with each other, even outside of a balance activity. So maybe when he's just sitting there and you ask him to reach for something, he might reach with both instead of just one. Short-term memory deficits. He's impulsive. Can't be out of bed due to a high fall risk. He's had 2 falls while he was in the hospital. What's this patient going to look like to you guys as a PTA? Yeah, mess. That's a really good way. He's not very coordinated at this point. He is the epitome of hot mess, right? Let's kind of go through these. So we talked about the scale. Visual acuity is down, right? And it makes sense. He had a coup counter coup down, so the back of his head is swollen. Is he probably going to have headaches too? Yeah, he's probably going to have headaches. Wernicke's aphasia. Do you remember what type of aphasia that is? What's the other term for Wernicke's aphasia? It's receptive aphasia, Mr. McKeever. So the other term for Wernicke's aphasia is receptive or non-fluent aphasia. Right? So he may not always understand what you're asking him to do. And when he speaks, he may say okay, but instead of saying okay, he uses other words that have nothing to do with what you're asking him. So he has occasional incidents, and that makes sense. Wernicke's area is towards the back of the brain. His balance, what's his balance like? His balance is like absolute crap, right? He doesn't have static or dynamic balance. And we'll see that with it. Positive Babinski sign. Do you remember when we started talking about upper motor neuron and lower motor neuron injuries? You remember we talked briefly about that? I mentioned that we're going to get into them a little bit more deeply. A positive Babinski sign is a sign of an upper motor neuron injury. What that says is the brain and or the spinal cord is messed up. Well, we know that he's got a TBI. He's got short-term memory deficits. All right, so he's impulsive. Past medical history, multiple incidents of past fractures, but at this point, all his fractures are healed. So he has no unstable fractures. He's good for it, right? Social history. The patient resides with his legal guardian since he was a teenager. Patient was previously a trapeze circus acrobat, but has recently become a full-time college student studying law. He trains physically between 5 to 7 times per week for about 2 to 3 hours a session. He resides with his legal guardian and a butler and has consistent, constant assistance at home. Patient's residence is a multi-story, multi-room family dwelling with patient's room being located on the 2nd floor. Patient's legal guardian says that the patient's room will be relocated to the 1st floor and will be provided with constant medical attention after discharge. Patient has no further social history. All right, so what do we know from just that social history there? What kind of stuff can you tease out from that? He's athletic, good, right? And because he's athletic, does that mean he's also going to be a bit of a pain in the butt? He may be, right? Because you're going to have him doing really basic stuff, and he's going to be like, I was just doing ring work yesterday, and now you're having me stack cones. So we've got an athlete. What's his home situation looking like? Is this a patient you're worried about going home? He's spoiled. He's spoiled. He's got a butler. But looking at this is not somebody where we're so worried about getting him, we're not concerned about his home care, right? We know he's got a lot of help at home. That's a good thing. Yeah, he has it made, right? This is perfect. He's like the ideal candidate for a traumatic brain injury at this point. So let's look at the eval. He has noted rigidity occasionally located in the upper extremities while resting, but he can relax it with conscious effort. So he has a little bit of spasticity, but if he focuses on it, he can actually relax it, which is good. He has a constant headache that's dull and achy in the back of his head. At the worst, it's 2 out of 10, 8 out of 10. Best, it's a 1 out of 10. He's usually about a 2. Okay, so we know he's got a little bit of a headache. We know if he gets up into that 8 out of 10 range, probably we might want to think about rescheduling therapy. You're in that 8 out of 10 range, not going to go very well. Range of motion, let's look at this. Grossly within normal limits. So active range of motion within functional limits. We know overall he's pretty good, right? Strength, he's got a little bit of 4. He's 4 out of 5 with some disuse atrophy noted. What makes sense? He probably had a bad banger. So what does grossly mean? That's a great comment. Erica goes, what does grossly mean? Because you may see this on evals. Yeah, overall. That's a fancy way of saying basically that rather than checking each muscle individually, rather than putting down that, shoulder flexion is normal. Shoulder abduction is normal. Shoulder internal rotation, normal. Shoulder external rotation, normal. Excuse me. It's saying that all of that, that's what grossly means. All of that is functional. Grossly just means overall everything looks good. So when you see grossly, think, oh, okay, so everything pretty much, it says, if it says grossly infunctional, that's when you should get concerned, because that means that basically everything, whatever you're talking about, it says, if it said like bilateral lower extremities, grossly infunctional, you're in trouble. That means the legs aren't working. This grossly basically says, hey, he's pretty good. It's a cheap way, and sometimes you'll see PTs use this. This is a cheesy way of getting out of writing out everything. Does that make sense? And I put this in here on purpose because what's basically happening is the PT didn't want to write down every single manual muscle test, every single range of motion. He's got some disuse atrophy. Well, he's probably bedridden for a couple of days, right? Or at least in the hospital. He also has a bit of a clonus response in the biceps. So what does clonus look like again? Do you remember clonus from patho and way back then? So clonus is when you're doing the manual muscle testing, you do your test and you let off and he does one of these. Right? He gets those fasciculations that don't stop and it's involuntary. And you may tell him to stop. And some of them can go, okay, it's calmed down. Others, you may have to help with that. So you may have to put some deep pressure. Deep pressure works to help with clonus. Ice massage works to help with clonus. Same thing that works with spasticity, right? You may just have to wait for it to kind of play itself out. That's a sign of an upper motor neuron injury. We know that his brain's kind of messed up to begin with. Transfers, let's see, bed mobility, standby assist, supine assist, standby assist, to min assist because of balance, right? Static edge of bed, min assist. Dynamic edge of bed, mod assist. Are you going to leave this patient by himself at the edge of the bed? Nope. Are you going to put a gait belt on this patient before you even move him? Yeah. This would be a patient that I'm not even letting him sit up before I put the gait belt on him. I'm going to weasel that gait belt under his back and put that on him while he's laying down in bed. Because this is a patient that will fall on you. Let's look at static, dynamic, right? Kind of weak. Ambulation, sit to stand as a mod assist, and he's got a pusher syndrome. He's pushing backwards. So that means where are you going to want to be with this patient when you're guarding him? Which way is he going to fall? Yeah, he's going to fall backwards, right? So you want to be slightly behind him, right? Whenever you're working with an adult, you typically want to be to the side and slightly behind. Because again, we normally as adults fall forward, right? Because that's where we are. If you're slightly behind, you can keep that. But if you also have a pusher, which most adults will push backwards because they're going to regress to that childhood kind of mindset, if you're back there, you can keep them from pushing backwards. Is he able to maintain static dynamic standing with min assist for greater than 5 minutes? But he's not able to do dynamic without mod assist. He's unable to weight shift on command when standing due to fluctuating balance loss. So he's not able to shift back and forth because he falls over. He's able to walk about 150 feet times 4 min assist. And he needs some cueing to maintain midline posture. During ambulation, the patient pushes posteriorly with his upper body and trunk. Again, you want to stay behind him. The note here, MD would refer the patient to stand in ambulance with the standard walker if the patient refuses to use it. Why do you think this? Why do you think he doesn't want to use a standard walker? What do you think he says about it? I'm not old. Exactly. That's for old people. So what does that mean you're going to have to do? You're going to have to convince him he needs to use this, right? How do you do that? Well, here's the deal, Dick. Right? Yeah, you got to put on your big boy pants right now. Do you want to go home? You know, this is time to break out the little card thing. Do you want to go home? Yes, no. If you want to go home, the doctor says you have to use this. If you don't want to go home, don't use the walker. Right? This would be a time where you have to be a little bit of him in order to get him to work. Right? This is kind of bargaining with him. We're going to go over the Berg balance scale again when we talk about balance with the vestibular, but Berg balance scale 20, that's worse than the last person we saw. So that means this dude's a serious fall risk. What the heck? Just had a gnat fly in my face somehow. So what are his goals? Resume training, get back to functional ambulation, and get his headache down. That's probably his main goal, right? He wants to get his headache back. So PT sets some short-term goals here, and we got our CPT codes, tell us what we're able to do. What do you think a lot of our session is going to be with this patient? What do you think we're going to spend most of our time doing? Gait training, exactly, Jar. We're going to do a lot of that and a lot of cueing. So that this patient's going to be split up into 2 main groups of work. We're going to do a lot of gait training and a lot of balance work. Do you think he wants his room moved to the first floor? No, he wants second floor. That's where his room was. I don't want to go to the first floor room. Gosh darn it, stupid gnat. He wants to stay on the first floor. Or wants to stay on the second floor. So he's not going to want it. So what are we going to have to work with him on? In gait. Stairs. Yep. Well, if you want to go back up to that second floor, buddy, we got to go do stairs. Right? He's not going to want to do it. He's going to be a little impulsive, right? He's going to tell you he can do it. Some of these patients we will be able to leave up in a jerry chair or a wheelchair after we leave them. Are we going to want to leave this patient up in a wheelchair? Nope. We're not even want to leave him up in a jerry chair. He's going to be out of it in a second. More than likely, what's this patient going to have on his bed? An alarm. Now, here's the thing. An alarm is considered a restraint. Even though he's not physically restrained, an alarm is considered a restraint. That means it has to be ordered by who? The doctor, right? How often does that restraint order have to be renewed? Daily, every 24 hours. So you have to be kind of paying attention to that, right? You have to make sure, sometimes you have to get on the nurses to say, hey, order's going to expire in a few hours here. They can take a verbal order from the doctor, but they have to renew it. The doctor can't write it for 7 days. They have to write it every 24 hours. That means if they've got ordered for that alarm better be on him when you lay him back down. Because I guarantee he's getting out of bed. You may have to have the bed rails up. Somebody said that, right? That's possible. He is going to try to cajole you to do whatever he wants. Well, I don't want to do balance today. Can we like play a game? I don't want to do therapy today. He's going to be another one of those. I don't want to do therapy today. What do you have to remind him of? You're in rehab. You agreed to come to rehab. You agreed to how many hours of therapy a day? How many hours do they get in rehab again? 3 hours. You agreed to 3 hours of therapy. You know, if you don't do this 3 hours of therapy, you're going to end up going to a nursing home. I guarantee you tell him that, he's going to get motivated. Because if he doesn't want to do the walker, he definitely don't want to go to a nursing home. You see how you're kind of going to work with this patient? So what kind of stuff could you integrate with him? What kind of stuff could you do that would maybe integrate some of his social history in order to get his buy-in to do therapy? Circus stuff, sure. He's also studying law. So could you do some stuff where he's maybe doing a little bit of cognitive work in standing? Maybe typing. Maybe, again, moving some books around. You know he's athletic. Find out what exercises he does at home and integrate those exercises into his program. If you do that, you will get buy-in, which means he will work harder for you. And again, if you keep reminding him that if you don't work here, Alfred's going to have to be changing your diaper. Or whatever his butler's name is. It will help. This is a patient you are going to have to use a little bit of negative reinforcement on. Telling him stuff he's going to lose if he doesn't participate, if he doesn't do what he's told. This patient is literally like a 9 or 10-year-old kid or 11-year-old kid. Right? He's going to want what he wants to do, but you have to be the adult in the room. Right? He's going to climb up on the dining room table while you're doing a comp. You're going to have to get him down off the dining room table. Right? So these are the things you're going to have to work with on this patient. Balance stuff. He's going to want to do balance stuff. That's stuff he likes. But he's going to be all over the place. So where would it be a good idea to do the balance work with him? What assisted device? Parallel bars. Yeah. Take him up to the parallel bars. And not only that, does that not integrate a little bit of acrobatic stuff? Is he not going to want to work at those? Oh, yeah, I use these, right? These are the straight bars. Maybe change it up, raise one of the parallel bars up and lower one of the parallel bars to challenge him. I wouldn't exactly break out a set of rings and have him start doing stuff on rings, but there's all kinds of ways you can integrate this stuff. Get his family involved because he doesn't want to see them, right? He's a teenager. Well, he's not a teenager anymore, but he's, you know, he doesn't want them doing all his work for him. He wants to do stuff on his own. But you got to remember, at this point, he is functionally a prepubescent kid. Right? So you've got to work with him. Does that make sense? Does that help you kind of visualize somebody like this? Is he going to say inappropriate things? Absolutely. What do you do when he says inappropriate things? The first time he says something inappropriate, what do you do? Usually the first time I redirect. With the TBI, the first thing I'll do is I'll redirect him. Oh, that's nice. Let's do this. Redirect him back onto what he's doing. If he does it twice, now I'm going to ask him to stop. All right, Dick, that's enough. Does it 3 times. Now we're going to start to get into some things that I'm going to take away from him. Right? Now I'm going to say, if you keep doing this, you know, we're not going to go outside for therapy. We're not going to, you know, again, is that just treating him like a kid? Sure is. But he's in that mind state, so you have to be focused on that. When you're walking him, you're going to want to be talking to him about his vision. What's your vision like? How are you seeing? Are you going to want to follow him maybe with a wheelchair too? You think you want to? Yeah, you probably do. Right? Because he takes breaks. So you're going to want a wheelchair there for him to take down. Or the other thing you might do is set up chairs. If you know that he goes 150 feet, set a chair up at 175 feet to challenge him. Okay, we did 150 yesterday. There's your chair down there. That's your break chair. Let's go get it. You see how a little setup can lead to a really successful exercise program with this patient, right? Just taking a little bit of time and thinking through it. You don't always have that amount of time, right? You don't have all the time in the world to plan these exercises. Excuse me. But even spending 5 minutes doing that can make your exercise program a lot more successful. I'm going to stop recording here.